Good morning, everyone, and welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. The Commission's strategic plan for 2020 through 2023 is committed to advancing the Commission's vision of well-being for all Californians. Cody, can you please bring up the strategic goal slide? Thank you, Cody. Now we will take roll and establish quorum. Jeff, can you please take the roll?
Commissioner Bontrager. Here. Commissioner Brown. Here. Commissioner Bunch.
Here.
Commissioner Carrillo. Commissioner Carnevale.
Here.
Commissioner Chambers.
Present.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Here.
Commissioner Gordon. Here. Commissioner Mitchell. Commissioner Robinson.
Present.
Commissioner Rolette.
Here.
Commissioner Tamplin.
Here.
Vice Chair Alvarez.
Here.
Chair Madrigal Weiss.
Here.
Madam Chair, you have a quorum.
Thank you, Jeff. We are now moving to Agenda Item 2, Announcements and Updates. The October 26th Commission meeting recording is now available on our website. The next Commission meeting will take place on January 25th in Santa Barbara, California. Please check our website for updates on the exact location and agenda. I'd like to welcome Kaylee Clark, a research supervisor for the Commission, who will provide an update on the Health Brains Global Initiative at this time.
Thank you, Chair Madrigal Weiss. This past summer, the Commission contracted with Healthy Brains Global Initiative to undertake a review of the current full-service partnerships contract. HBGI is an internationally recognized global nonprofit with a goal to increase the reach and impact of mental health services. HBGI's area of expertise is the use of outcomes or performance-based contracting. Their chief medical officer is Dr. John Sharon, former director of behavioral health in Los Angeles. The HBGI team was tasked with exploring the performance of FSPs with a particular focus on contract design and performance management. They considered if and how outcomes-based contracts could enhance FSP performance or otherwise strengthen California's behavioral health system. Over the course of the summer, they consulted with statewide stakeholders. They also spent 3 weeks doing a deep dive in 4 counties, where they met with county behavioral health teams, service providers, and service users. A draft of their report is now being circulated as a discussion document with behavioral health directors across the state. A final version will be delivered in early December. If any counties would like to take up the recommendations, HBGI will work with them to determine the technical assistance needed.
Kaylee,
Yep.
I'm sorry, I'm going to ask you to pause just for a moment. We have a terrible echo, so it's really hard to understand what you're saying. So Cody, I don't know if we can get some assistance.
Callie, can you just make sure your computer is muted? The sound is muted? Go ahead and try again.
Okay. Chair, I'm just going to continue from where I was, if that's fine.
There continues to be a heavy mute. There a heavy reverb.
Okay.
Okay, I'm sorry. Try one more time. Let's see if this works.
Okay. Is that?
Nope, sorry. Yeah. Kelly, I think we're going to move on to the next announcement and come right back to you, and Lawrence is going to do some troubleshooting.
Okay, thank you.
Thank you, everyone. So then at this time, I would like to invite Commissioner Brown to provide us a debrief on the town hall and site visit in Susanville. All right, so we are going to move on. Commissioner Brown had to step out. So then I am going to invite Vice Chair Alvarez. Vice Chair, please, if we can have an update on the CLCC committee.
Sure. Good morning. Oh, I hear an echo.
So we don't hear it on this end, but
Oh, great.
we hear you
Hopefully-
just fine, and hopefully everybody online does too. And if you do not, I hope somebody will tell us, but we hear you just fine on this end.
We're getting reverberate.
Okay, so you're hearing echo on that end. Thank you for letting us know. Okay. Then, Vice Chair Alvarez, just one moment. We will have the team work on that. Thank you, everybody, for your patience.
I've read that it seems to be the remote callers because we hear Mr. Manuel-Wise without an echo, but everybody is on remote is echoing.
Thank you, Commissioner Danovich. So if we could, we'll just take a 5-minute break until we work it out. We will have the team look at that. Thank you, everyone, for your patience. Commissioner Alvarez, could I ask if you could say a few words so we could test out the system?
Absolutely. Can you hear me okay? Because I am not hearing an echo on this end.
Yay, we hear you perfectly. So, could we ask if Commissioner Danovich, if you hear Commissioner Alvarez fine?
Yep, no echo seems to be resolved.
Hey, all right, reset. We are good to go. So if we could go, we're gonna backtrack just a little bit. I am going to go back to Commissioner Brown so he could provide us that the debrief on Susanville, and then afterwards, Vice Chair Alvarez, if we could have the update from the CLCC. How does that sound? Good? All right.
Just 1 second here. Let me pull something out. So last week, senior researcher Courtney Ackerman and myself and commissioners Mitchell and we traveled to Lassen County to do a study on the impact of firearms and firearm violence in a rural community. And Courtney had done some great legwork in terms of getting some things set up. We had a town hall meeting, our first evening there, which was really a great experience. We had about 20 people there. The variety of people was tremendous. We had the chair and another member of the Board of Supervisors. We had the sheriff. We had the Veterans Services Officer. We had an assistant CEO from the county. We had representatives from a youth shooting sports league, a clay pigeon, a skeet shooting club that was there. And we had a variety of other veterans and other people who came to the evening. And we had a great dialogue with members of that community, and very, very frank and at some points difficult discussion about the fact that the county has a tremendously high suicide rate by firearm, for example, and talked about some of the issues there. And it is a rural county. It is a county in which firearms are very prevalent, and the general consensus was that because of their availability, their significant availability in the community, that's probably the reason that they have a higher rate of suicide. But nevertheless, we discussed ways that they can work to address that rate and try to bring it down and try to make sure that there's more services available. They are struggling, like many communities, with budget and with resources. Their mental health services director, acting director, was there, and she also participated in the meeting. And it was a really, really great opportunity to get some great feedback for the commission and for the committee in particular. And Commissioner Bunch also was there, and I neglected to mention her. But we had, the following day, we had a visit to the community college, where they have a very novel gunsmithing program that they actually do a training course for people. It's one of 4 certified gunsmithing courses in the country. And again, it just sort of, it underscores this long-standing, significant relationship with firearms that that particular community has, in the form of hunting and competitive shooting and what have you. And the county has also been hard struck economically by the closure of one of 3 prisons that was in the county. And so there were some major issues that they have struggled with, and not, frankly, very typically very trusting of Sacramento and state government. And there was some, I think, some initial concern about what were we there to do. And then once we really, explained what the situation was with the committee and the report that we're working on, the study that we're doing, they really did participate very, very genuinely, and very appreciative of all the legwork that went into that. And so I appreciate Courtney setting that up and everything that was put together for us on that.
Thank you for that. And I just, again, congratulate the staff. I think the site visits around this have been really well done. And I want to thank both Commissioner Bunch and Brown for your leadership on this. But I really look forward to what we're going to learn from this and how we can really support our state in doing something meaningful with everything that we're learning. So thank you for that. Thank you, Commissioner. At this time, Vice Chair Alvarez, if you could please provide us that update on the CLCC committee.
Absolutely. Happy to. And so far, I think I don't have an echo, so great. Okay, I'm going to go forward. Good morning, everybody. I'm excited to share that the CLCC met last week on November 8th. The committee had an opportunity to hear an update from our Deputy Director, Norma Pate, particularly around the 2024 to 2027 strategic planning effort. Commission staff have really done an excellent job of community outreach around on the plan, and many of our public comments really responded to that. So just want to give our deep kudos and appreciation to staff for the work that they're doing to ensure ample public comment and input is provided on the drafting of that plan. Additionally, public comment really identified where the opportunities lie for engaging important committees like the CLCC in the work moving forward around the strategic plan. So looking forward to that as we move forward in that process as a commission. The committee also heard a presentation from Ruben Cantu, who is the director of the Prevention Institute in Oakland. In particular, he spoke about a contract that the commission issued to the Prevention Institute, particularly around how community-defined evidence practices can be included in the long-range planning at the county level, and how communities of color and other marginalized communities can be engaged in the process as behavioral health programs are considered. Ruben shared an important presentation that really highlighted the importance of building trust with marginalized communities through authentic engagement and by incorporating their input into the overall behavioral health planning, and offered some concrete opportunities to have the commission consider in our work moving forward. The discussion around that report was informative, but also inspiring for, again, what the work ahead looks like, particularly around our strategic planning process. Additionally, the committee had planned to hear a presentation from Dr. Cheryl Grills, particularly on the phase 2 CRDP evaluation. And if you might remember, CRDP stands for the California Reducing Disparities Project. We actually ran out of time and wanted to make sure we gave Dr. Grills the necessary time on the agenda to share these important findings. Recently, the CRDP held a few public sessions across the state that commissioners were invited to, commission staff attended, and we want to make sure that that information comes back to the commission. So rather than try to rush that presentation, because it does include such rich information on outcomes, we want to table that conversation for another time and are exploring opportunities for the entire commission to receive this information, again, related to the work that is happening not only with our own strategic plan, but with other statewide initiatives like the Children and Youth Behavioral Health Initiative, and really speaking to the alignment that is possible when our agencies work together. So want to table that conversation and really want to extend our deep appreciation to Dr. Grills for her patience in that process. I hope, again, that as we move forward with our strategic planning, we do identify these opportunities to continue to hear from valuable members of our public, but in particular from these organized entities like the CLCC, who do have these unique perspectives on what a culturally competent and linguistically competent behavioral health system should look like. We are fortunate to have the expertise of our members and, again, the input of our community. And I just want to extend appreciation to the commission as a whole and the leadership of our chair, who has really sought to put into practice a commitment to uplifting our community voice. And want to just also extend our appreciation to the committee for the work that they've done thus far. So looking forward to working together to build that more effective behavioral health system together for all who call California home.
Thank you very much, Vice Chair. Excellent points, and I do look forward to seeing how we can bring that information and continue to braid together the initiatives and, important pieces. So thank you so much, Vice Chair. At this time, I'm going to ask that we have Jeff, our chief counsel, give us an update on the changes that will take effect next year as of January to the Bagley-Keene Open Meeting Act. So this is important as it will definitely impact our work.
Thank you, Madam Chair. SB 544, authored by Senator Laird and signed by the governor in September of this year, will take effect next year, and it makes changes to the Bagley-Keene Open Meeting Act, as the chair indicated. And I just thought I'd spend 1 second here bringing up a change. There are several changes in the law, but I thought I'd bring one up, and I may be asked to remind you again as we get into next year. But one of the most significant changes to the law is the fact that we can still conduct meetings via teleconference or what we call hybrid around here. However, there is a new rule that the majority, and the majority is sort of synonymous for our purposes as quorum, must be physically present at the meeting location. So in the future, starting January of next year, we just need to be cognizant of the fact that commissioners, at least the quorum, the majority, need to be physically present in order for us to conduct business. I'm pleased to say, Madam Chair, that sitting here today, we would meet those requirements. But we will have to see going forward. The COVID sort of changed the world for not just this commission, but all boards and commissions that got in the habit of meeting via teleconference. But some of those rules have changed, and that will impact the commission going forward. Thank you.
Thank you, Jeff. Are there any questions regarding that?
Just confirming this January.
Yeah, so the legislation passed through the legislature during this legislative session, and unless, and Kendra, our legislative director, can explain this to you better, but unless there's what we call an urgency clause in the legislation, the natural is for bills that pass and are signed by the governor during a legislative term take effect January 1 of the following year.
Okay. So, in talking with Jeff about this, so my understanding is, if we don't meet that, then anything on the agenda would turn into informational, and we could not vote on anything, so.
That's correct. There are a couple of exceptions if somebody has a very specific reason why they cannot why they cannot physically attend, such as disability and otherwise, that we can deal with if that situation were to occur. But the general rule is we must have a majority physically present.
Okay, thank you. Thank you, Jeff. So at this time, our final announcement is on one hand exciting for our behavioral health system, but on the other hand, sad for the commission. Commissioner Tamplin. I'm going to just say, please go ahead and share your exciting news with us, and then we'll make comments.
All right, thank you, Chair Madrigal-Weiss. It is with mixed emotions that I share that I am resigning from the commission effective December 1st. I have been, I've accepted a position with the U.S. Department of Health and Human Services, Substance Abuse, Mental Health Services Administration, I'll say the full name, Office of Recovery. Very excited to join SAMHSA's new Office of Recovery. They've and continue my work in this field as a federal employee. But in doing that, I also have to resign from this commission, unfortunately. But I will be hopefully partnering and collaborating with everyone as I have, before joining the commission too, and look forward to working with everyone. I've been on the commission for 10 years and I actually was a committee member before joining. So in 2008, I was part of the Klein and Family Leadership Committee, and it was just a huge honor to be part of the OAC in some form and see how much MHSA has made an impact in people's lives and my life. I am honored and humbled to be able to work with such dedicated commissioners, stakeholders, and commission staff and leadership. It's been a true honor and such a remarkable journey for an opportunity. And I'm excited about, the new, I fill a seat that's for people with lived experience with mental health challenges. So I've struggled and for someone to, who came to this country as a refugee to get this kind of opportunity is, I think, a testament to how inclusive our state is and how much also recovery and people with lived experience really make an impact in being part of this this commission. And so I'm excited about the next commissioner that gets appointed to this seat, as I have been with getting to know each one of you in your leaderships. And I'm also leaving the county, obviously, so I'm so humbled that my team is here. My God, thank you so much, Shani and Arita, for being here. And that's all I gotta say. I'm excited and sad at the same time.
Thank you, Commissioner Tamplin. So I'm going to just say a couple of things business-wise, and then I'm going to say more. For an entire decade, you have been one of the pillars here at the Commission. You have consistently and effectively provided the Commission with a consumer and family member perspective and have acted as a mentor to all of us and the Commission staff along the way. Thank you for always working hard to make sure peer voices were heard and for testifying in front of the legislature to support peer certification. We can now proudly say that California has joined the list of states who have a peer certification program. We will miss you, but look forward to working with you in your new role. We look forward to having you come back at a future commission meeting to do a more formal recognition and provide you a beautiful plaque and stand up and take wonderful pictures. This was very short notice. I want to say that you inspire me. You've taught me so much about leadership in this role, about lifting up voices, about living with lived experience, and just have really taught me to be a better advocate all the way around. So I am deeply honored to not only be a colleague, but more importantly, a friend. So thank you for all you've done for this commission. My deepest respect. I would like to open it up to fellow commissioners for any comments to Commissioner Tamplin. I just. Please.
So I'd written a few notes here, and Chair Madrigal-Weiss covered most of them already, but some of them bear repeating. I think you've had a very unique personal journey, and your story is amazing. And the fact that you came to this commission 10 years ago when I was fairly new on the commission, and have been a fixture on it, really, and as far as I'm concerned, and really one of the positive elements of this body. You've always had a great attitude, a great smile, a great warmth about you that has been, something that really stands out. You've been vivacious and bright, and you're upbeat, and you're just a great colleague to have on a board like this, a commission like this, rather. So thank you for all of what you've done. You've been a great advocate for peers and peer run organizations. You've taught us the great positive elements that can be brought to mental health treatment and service by having peers involved at the line level and engaging with people who are struggling with mental health challenges, and you taught us about the value of that. So thank you for that. We're going to miss that great smile and that determined can-do attitude that you bring to the commission. And the Fed's gain is our loss, but Godspeed. And I know you'll do great work in your new role.
Commissioner Chambers, and then Commissioner Gordon, and then Vice Chair Alvarez.
Thank you. I know we're in public, so I'm gonna try not to cry because it's gonna be on record. But I'm so honored to know you as a human, as a colleague. You've completely changed my life and the life of a lot of Californians that suffer from a mental disorder and substance use disorders in California. You inspired me as a Black woman of color, a business leader, to take my story and elevate it and to be unapologetic, to get up in front of the legislator and advocate when I was scared, to talk about the issues. You made me believe that I could even serve our great state of California, with a mental disorder. You showed up to me when I was in crisis and struggling. And I believe that's what colleagues should do, especially when we want to lift each other up. I just want to say thank you for now making peers like our workforce a household name in behavioral health. I believe everyone even the governor really now knows like the value of our workforce, that we have competencies, we can run companies, we can provide quality, integrated, culturally appropriate, linguistically appropriate services. And I just want to honor you. And I believe this seat it's a loss for California, but we will be elevated at the federal level. So I'm going to hold you to that, to tell Biden, let's get a peer certification bill. But yeah, thank you for being there for me and being just an example of what professionalism is, how to carry yourself. You literally inspired me, like I said, as a woman of color, to level up, to show up, be present, unapologetic, and advocate for yourself. So thank you for loving me, loving my family, and bringing me here to serve California. Thank you.
I don't want to repeat much of what others said, but I'll just say what a privilege it is to have been able to work with you and hear your perspective and get your advice over the years. And I won't, because we've been on the commission around the same length of time. But just one of the things that you inspired in me and in us that we're doing right now today is we're using peer specialists as part of our pipeline to increase the supply of mental health clinicians. And we're going into high schools and recruiting peers and giving them salaries to do the work, because the young people of today are going to be our mental health service people of tomorrow. And the excitement that young people have about moving into this field, I think you've made a huge impact, and we will miss you, but the feds are fortunate to get you.
Vice Chair Alvarez.
Thank you, Chair Madrigal-Weiss. Commissioner Tamplin, I just want to echo everyone's incredible words of appreciation and love for you. I feel it's been a true honor and privilege to know you and to serve with you. You really have been an incredible champion for mental health broadly, but also in specifically lifting up the lives of individuals with lived experience. Your knowledge, dedication, and leadership around promoting peer support and again, empowering people with mental illness have made a difference, not only here in this commission, but in the state of California. And to know that that tireless advocacy will be carried on to the national level, we are all so fortunate to be able to have you at SAMHSA. And I just want to really extend deep appreciation for all that you've brought to my own learning journey in this work. There is no stronger advocate for ensuring that the voices of those with lived experience are heard and respected. And that has been incredibly inspiring to watch. Your leadership in shaping the policies and programs around peer support has fostered this like incredible culture of compassion and understanding within our community in ways that truly would not have been possible without you. And you've also fearlessly committed to breaking down stigma and discrimination, and that like unwavering, relentless advocacy has just been a beautiful thing to witness, a beautiful thing to be a part of. And I am entirely grateful to be able to have been on this commission with you. Again, I think we are all grateful for the legacy of service that you've provided, but we're also incredibly grateful that you're carrying that forward to the national level to lift up what California has been doing and to demonstrate that we can do things differently at the national level and we can demand better for our communities, particularly people living with mental illness. And on a personal level, you have shown me what it's like to be a working mama, to find a balance between taking care of ourselves, our families, and our broader community. And I am entirely grateful for that as I continue to learn what that looks like. And I'm looking forward to continuing to champion you, to support you, and to be inspired by you. We will miss seeing you, but I'm looking forward to continuing to work together. Congratulations.
Commissioner Danovich.
Thank you. I would echo everything that's been said, and in the spirit of brevity, I won't restate, but I'll just highlight that Commissioner Tavlin, I appreciate your commitment to advocacy, your openness, your grace, your dignity. I've learned a lot from you, and it's been just a complete both privilege and pleasure to serve together with you. And so it is bittersweet, but I'm thrilled for you and for us, and I wish you all the best. Thank you.
Commissioner Carnevale.
Ditto is one, and I just wanted to add that the unexpected aspects of joining this commission is this richness of professional and personal interchange that happens between the commissioners that creates this rich tapestry of learning. And Commissioner Tamplin, you've been a very significant part of that for me personally. And I know you will bring your jujitsu skills to SAMHSA and successfully wrestle some of those issues that you're going to grapple with successfully in your journey. And I wish you well and look forward to seeing you in that capacity.
Commissioner Brown. Commissioner Bunch. The bees, sorry.
I think I've said most of what I need to say through my many hugs that I've given you today. Congratulations on your new phase, and thank you for all the work you've done for the commission. Thank you for inspiring me. I feel really lucky to know you as a person, and I feel even luckier to have learned from you and to have been able to work with you on this commission. I think mostly I just want to say that I'm going to miss you, but I know that you're going on to do great things, and I will still see you even if I have to show up on your door.
Commissioner Rowett.
Short anecdote, R becomes before T, and so I want to speak to your individuality, intellect, and integrity. We serve here and on another committee. We did serve on another committee. You left that committee as well, their loss. And I was a part of a vote, and anytime you're new to this body, and my vote was different than what it appeared to be the majority, and I wondered Okay, am I missing something? And then you voted the same way I did. I said, I didn't miss anything. And it just speaks to your intellect and integrity and individuality. And that I admire. Again, it's a unique attribute that you will take with you, I know, and that will be represented in the venues at SAMHSA. So congratulations to you. I certainly have been the benefactor of it.
Commissioner Robinson.
Thank you, Chair. I don't want to restate what's already been said, echo the previous comments. I think I'm the newest commissioner, and I feel cheated. I want to make a motion that we not accept your resignation. I got a second already. But I took a look at your LinkedIn profile, and what I can determine is that there's been a consistency of purpose in your career. And I think California is better for it. I think that we all are better for it. So thanks for what you've done. And I look forward to hearing about the great things you're going to do. Congratulations.
At this time, I would like to have a few moments if there's any members of the public that would like to say just a few words. I would invite you to do so now. We have somebody from the audience. Stacy.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Katera, this is a surprise, but it is a great surprise. Although I know the commission will miss you, SAMHSA is so fortunate to have such a fierce champion for client, consumer, and people with lived experience. You have been an example for so many and have led the way, and we have looked to you as a voice, sometimes particularly before Commissioner Chambers, and sometimes you know the seat was empty, so you have always held the light and always kept your word to the consumer community. So good luck and thank you.
I see one hand raised. So Jamie, if we're going to go ahead and take that comment.
Hi. Oops. Can you hear me?
We can hear you fine.
Sorry. Hi, Katera. This is Jamie Yan Farrow. I just want to take this moment to say it's been a short time that I got a chance to know you, and want to say just don't forget about us here. I know you're in SAMHSA, and there's a lot of amazing work. I have met a lot of amazing leaders through SAMHSA, and not forgetting you. And you know, I know you will do a lot of wonderful things there, but just help us, right? You know how hard it is to get works as a peer to talk to people from SAMHSA. I hope you will help us, connect us to build meaningful pathway and collaborations with them, so that our voice as a person with peers will get amplified, so that they be more meaningful collaborations, especially for us who are people of color. Not many of us get a chance to be able to have our voice enunciated, and also, you know, because I'm a peer and community advocate, those who are marginalized, underserved, and unserved. I kindly ask you to help us help ourselves be the champion, and I hope we can stay in touch. Thank you again for your amazing work, and congratulations. Thank you.
Thank you, Jamie. We are going to take one last comment, and that'll be for Andrea.
I think the stars were aligned because I just hopped on and heard Katera's leaving and SAMHSA, and so my heart sank. I'm filled with joy to know that, to hear you're have some role with SAMHSA, which is super exciting. I know that your voice to be lended at the national level is just amazing, and I'm so happy for you. But what a loss for California, and end of an era. So I'm sure you'll still be present, but just Katera, I from the bottom of my heart, thank you so much for your leadership and your voice. You have made such a difference in our client movement in California, and I just thank you for that. Best of luck to you.
Thank you so much. I am just so blown away and for all the love that has been shown and just really can't thank you all enough. I'm at a loss of words. Some of his emotions are just still piling up, and but to the piece about bringing hopefully a bridge between our community, our work locally, and the federal government. I definitely will be continuing that advocacy and working collaboratively with the team that I joined at the Office of Recovery and the team that I have here in California throughout the state with the wonderful, incredible leaders that are sitting at this table, on this call, throughout in this room, throughout our communities, doing this important work to help people along the recovery journey. That's what we're all here for, is about recovery and resiliency and family and community and all our diversity coming together to make such a impact, not just nationally but globally. So it's been a true honor, and I continue to will be an advocate for all the work that's being done here, and look forward to partnering. And thank you again for just the very kind and loving words. Thank you, Madam Chair.
Thank you. Thank you. With that, we are going to move on and take a deep breath here. I also would like to make an announcement and congratulate my fellow Commissioner Mitchell. She was recently reappointed by Governor Newsom, and she fills the seat for family member of a child, of a child with mental health needs, correct? And so congratulations, we're so happy that you were reappointed, so awesome for that. Initially appointed in 2016, correct? So, yeah, so if you'd like to say something.
No, I just, I'm sitting here and I'm listening and I'm trying to manage the emotions. So Commissioner Tamplin, you were always extremely open, so I understand what Commissioner Chambers is saying. I reached out to you one time when I was having an issue with a relative, and you've always been just so kind, and you always had to smile, like everyone said, so I won't repeat what everyone has said, but you will be missed. So congratulations and thank you for those moments, because we all have a story. So thank you. And thank you, Chair. Yes, I was reappointed, so I'm here. Hopefully I can be regarded as well as trying to uplift families who have children with mental illness.
You are highly regarded, Commissioner Mitchell, so thank you for that. I want to welcome everyone again to today's meeting. The plan is to end approximately at 2:45. So, Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so the Commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for Agenda Item 3, General Public Comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. We currently have 2 public comments. We have 1 in the room and 1 online. First, we have Stacy.
Good morning again, Commissioners, and congratulations, Commissioner, on your reappointment. We look forward to working with you. As Commissioner Alvarez said of the Cultural and Linguistic Competency Committee, the long-awaited report on the California Reducing Disparities Project was postponed due to time constraints, but there was consensus on the committee that this report really should be on the agenda of the full commission as it relates to all the work that you do on all your other committees. So I'm really urging that this happen. And I did want to say, since Commissioner Tamplin's going to SAMHSA, we just had a meeting with SAMHSA, and they were totally impressed. They are going to be taking up something with us. And again, if you meet somebody from SAMHSA and they say, oh, the California Reducing Disparities Project, you want to know about it. So again, I hope that this report will be on the full agenda. And if I can't convince you just that way, I really wish that you could all meet Dr. Cheryl Grills, who is the principal investigator and author of this report, because she is one fabulous, fantastic woman. She is a clinical psychologist as well as a well-respected researcher and evaluator. And she is at Loyola Marymount and is the head of the PARC, which is the Psychology Applied Research Center. But she was also on both at the state attorney generals and at the national task forces to develop recommendations on reparations for African Americans. So she is extremely well known, but she's a delight, and she knows her audience. She doesn't make the evaluation just boring and throw facts at you. And her team is, again, extremely diverse and will make this relevant to your work because it has to do with CDEPs, or community-defined evidence practices, and the commission will be in charge of developing priorities for early intervention if Proposition 1 passes. And in the language in the legislation, CDEPs should be funded under early intervention, so you really need to know what they are and how to support those. So thank you very much.
Thank you, Stacy.
Next, we have Richard online. Your line is open.
Good morning, commissioners and staff. I just wanted to bring up the issue at the last October commission's meeting where I was not able to join during public comments. Even though it may be technical difficulties, but I strongly feel that it was intentionally set, blocking me from being able to give my comments during public comments. That's my gut feeling that's telling me. Because I wanted a response when Commissioner Mitchell asked a staff member regarding the peer support question with the Santa Cruz County Innovation Grant 2 months ago. The gentleman that responded back to the commissioner with dishonesty. There was no miscommunication at all. I go to the monthly meetings with the County of Santa Cruz Mental Health Advisory Board. I know what's going on. I know what's happening. For him to be dishonest to the commissioners, the entire commissioners, is unacceptable. That innovation grant that the commission approved was not a complete application. There's blank spots in there that wasn't even filled. It was left blank. Who they're gonna hire, who they're gonna pay, who's gonna be the contractor. That's not how it works when you're voting any kind of plans. So I just want to make sure and be clear on record. That was not okay. Unacceptable. Secondly, Andrea Cook, her mentioning her public comments regarding her concern about the advocacy grant, her concerns about peer support. I stand with her because when the second round grant of advocacy came out, it was not done ethical. It was done with retaliation, which is why Cal Voices did not get the grant. Loud and clear. We had ambassadors throughout the state that did great work at the county level and at the state level. The problem you have is staff of the Oversight Commission do not understand the definition of advocacy. Advocacy from the peer workers' perspective, advocacy from the disability perspective, advocacy from the mental health perspective. All of you can go online and look at No Pity with Dr. Paul Longmore Institute about the Section 504 protests. That is a perfect example of advocacy. And that's what we did with the Access California program with Cal Voices. Andrea Cook was an incredible trainer, an incredible mentor. She taught all of us about the importance. But part of the problem with the Oversight Commission is there's no open door policy, especially with the staff and particularly the executive director, Toby, of the Oversight Commission. He plays politics behind closed doors. He was part of the issue,
Thank
part
you,
of the
Richard.
problem
Your time is up.
is
If you
why
please
we
wrap up.
lost our grant. Yes, I just need to make my point and then I'm done. So the commissioner needs to be aware of this. So there was no misunderstanding. Thank you.
Thank you, Richard.
Next, we have Jamie. Your line is open.
Hi, everyone. Again, this is Jamie Infero. I'm a BIPOC peer and community advocate. I represent myself. And I just want to actually come forward with a humble request for the commissioners to bring about something that I think we need to address in the greater scale, because as you know, in the larger scale, there's a lot of unrest, a lot of hurt and suffering through war and with the communities of color. And there's a lot of cultures who's actually impacted because there's people being attacked in the sense of race and disparities. I'm talking about racial disparities and social disparities, especially in the rural communities. I belong to a rural community in North Bay in California. And I'm just wondering, are there any ways we can actually bring about mental health in a way that we can help heal communities of color? to be able to dive into a way that we can look at it culturally to address the subculture in it. Because if we actually address the issues people of color, not all people of color heal the same way. And rise of suicidality is actually going up and up. And if we want to really talk about with commissioners, can we look in the way that we can help peers, people live experience, especially during these festivities. A lot of people live alone, and there's a lot of people who really need extra hand of support. If we want to think about issues that support the disparities, the people who, the population, the diverse population, I think we need to find, like for 2024, to think about ways to support our community, not only those who are actually prudent and obvious in the front that actually been hurt, but those who are actually unheard in the background. And I'm, as a peer advocate, I like to come abroad to propose that can we come together as a community to help those who are hurting, those who are actually marginalized, underserved, and unserved. Usually I go to Katera with issues like that, but now she's not in the position, not with us, sadly. Who can I go to? Can I propose this to you, Toby? And propose to other commissioners if we can all work together? I'm coming in front to Stacy, to all these leaders in the front. If we can come about a solution for a longer time to see what we can do together collaboratively. That's all I'm trying to propose today. Thank you.
Thank you, Jamie. I'm going to invite you to go onto our website and really look into the activities of our two committees, the CLCC and CFLC. I think you can engage in conversations there and really look into the work and the activities that those groups are doing. So I encourage you to do that, please. So at this time, we are going to go ahead. Thank you, everyone, for your comments. We are going to go ahead and move on to agenda item 4 and consider approval of minutes from the October 26th commission meeting. I would like to invite commissioners to offer comments or questions. And we can take on public comments regarding the meeting minutes. Are there any public comments regarding the meeting minutes? Mariani?
I see no public comments.
Thank you. Then I would entertain a motion.
So moved.
I didn't see. Thank you, Commissioner Robinson. And a second.
Second.
Thank you, Commissioner Bontrager. We have a motion and a second to approve October meeting minutes. I did not initially see any questions or comments regarding the meeting minutes, so Jeff, I would ask that we take a vote.
Gladly. Prior to reading the roll, I just want the record to reflect that Commissioner Mitchell is physically present here for the meeting. Now the roll on the motion. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell.
Approved.
Commissioner Robinson.
Aye.
Commissioner Rolette. Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Approve.
Motion passes.
Thank you, Jeff. We will now move on to agenda item 5, where nominations for chair and vice chair for the 2024 year will be entertained, and the commission will vote on the nominations and elect the next commission chair and vice chair. I will ask Chief Counsel Jeff to please facilitate the process.
Thank you, Madam Chair. On an annual basis, the commission elects a chair and vice chair, and those offices take effect January 1 of the following year. We are now at that step in the process where the commission will be electing a chair and a vice chair. The way the process will work is we will open the floor for nominations, first for chair. We will handle each office separately. So we will open nominations for chair, and then we will give each nominee an opportunity to speak. We will hear comments, if any, from the public, and then we will accept motions and vote on the motions. So with that, are there any nominees for chair of the Mental Health Services Oversight and Accountability Commission for 2024?
As a clerk, are there term limits, or I mean, are there any requirements or restrictions?
There are not any term limits or restrictions other than we have elections on an annual basis. There's no limit with respect to existing office holders or previous office holders.
Yes. So, oh, go ahead, Steve.
Yeah, sorry, I moved to my phone, so I don't know how to raise my hand. I just wanted to, it's my honor actually to nominate our current chair, Magna Weiss, to be reappointed for another year as our chair.
Second.
Third.
Fourth.
Are there any other nominations? If not, what we should do is give the nominee an opportunity to speak, and again, then hear from the public if there are any comments, and then we can vote on the motion. Madam Chair.
I am honored to be nominated and happily accept the nomination, the faith and trust and support that I have of fellow commissioners to continue to serve in this role. I take seriously and happy to do it.
Are there any comments from commissioners at this time?
I would love to just thank you for your exceptional leadership and your dedication to, chairing these meetings. And these are not easy, and you always come with your heart, your passion, your expertise of navigating even those challenging times and making them, move us through it, and also stay very focused on where our goals are as a commission. You really have demonstrated and modeled leadership in this role that I think is hard to fill. That's why it's so incredible to see everybody just aligning with that, and just want to appreciate you for your mentorship over the years. So I just needed to add that piece. Thank you.
I would like to add to that as a practical matter. I know it's unusual. Normally the chair rotates more often, but I think that given all of the movement that's going on with the governor's mental health modernization plan and the implications for the commission, that it's really helpful to have our current chair continue in this capacity to help us navigate through those interesting waters, shall we say.
I would just like to second what Commissioner Carnavelli said. I mean, as a younger commissioner, I've seen your leadership just teach me the balance of like what's the bigger picture, and I think you have that, and you know how to navigate different spaces, different like communities, different stakeholders. I believe you have all the skills necessary to continue to elevate our work and to get us in spaces and rooms where we need to be to make sure our people, because at the end of the day, like you said, it's about the people. And that's why I align, even if I don't necessarily agree. I know that you have the best interest of the people, and that's why I am happy to be mentored by your leadership, and I feel like I'll be able to learn more. So when it's my time to, put my hat in the ring, I'll be ready and follow like Commissioner Tamplin did too, as a peer chair as well. So thank you. Hopefully you accept it. Sounds like it.
Thank you. And did you call me a senior? That's what I heard.
Sorry. I was like, what?
Any other comments by commissioners at this time? If not, we'll now invite the public to make comments if they have any, following the same procedure that Amariani announced earlier in the meeting. Do we have any public comments?
I don't see any online or in the room.
Seeing no, thank you, Amariani. Seeing no public comments at this time, we have a motion made by Commissioner Carnevale and seconded by Commissioner Bunch that Mata Madrigal-Weiss be the commission's chair for 2024. At this time, I will take roll with respect to the motion. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Enthusiastic aye.
Commissioner Gordon.
Enthusiastic aye as well.
Commissioner Mitchell.
Yes.
Commissioner Robinson. Aye. Commissioner Rolette.
Yes.
Commissioner Tamplin.
Yes.
Vice Chair Alvarez.
Absolutely, yes.
Chair Madrigal-Weiss. Well,
Yes.
Madam Chair, I'm pleased to report that you have been unanimously re-elected to chair the commission in 2024. At this time, we will move to vice chair of the commission for 2024. Similarly, as we did with chair, we will open the floor for nominations for vice chair.
I'd like to.
I'd like the honor to nominate our current vice chair, Mayra Alvarez, to continue in her exceptional leadership and support of the commission also.
I'll second, since that's who I was gonna also nominate.
I'll third.
Are there other nominations? At this time, we have a nomination and a second for vice chair. At this time, we'd like to offer the opportunity to Vice Chair Alvarez to make any comments she would like on her nomination.
Thank you, Jeff. And thank you to my fellow commissioners for the opportunity to serve again. I want to accept it wholeheartedly and really see it as an extension of your faith and trust in the work that I do to support you all and to support our chair, Madrigal-Weiss's leadership. It is an incredibly exciting time for the commission and for the opportunity to improve mental health of all Californians. And I'm honored and privileged to be able to serve in this role, to be a part of the team that is doing all it can to take advantage of this opportunity. There are a lot of people suffering and hurting, and there is so much more we can do as a state with what lies ahead. And to be a part of that work with you, again, it is a true honor. So I wholeheartedly accept it with energy, grace, and a deep sense of responsibility for the work that we can do together. So thank you.
Are there other commissioners that would like to comment at this time? Are there members of the public that would like to comment following the same process that Mariani described previously?
I would like to make a comment because I want to add that, again, Vice Chair Alvarez, thank you so much for your leadership and, as you said, your support of the commission and the roles, the leadership roles that the two of you have, both you, Chair Madrigal Weiss, and yourself have been just exceptional, and navigating again all these, what's coming down, you know, in 2024. It's wonderful to have strong leadership continue to support as was already shared. And then just uplifting the fact that, you know, having two women leaders continue in this role, I think there's something to be proud of in that, and to see it continue. I look forward to watching your continued success and leadership from afar, but close in terms of connection. So I'm so happy for this commission and where it's going towards for 2024 and navigating all that's coming down the line.
Thank you, Commissioner Tamplin. Any other commissioners? Okay, at this time, we will invite members of the public to comment. Mariani, do we have any public members?
Yes, we have one in the room. We have Stacy, and then we have one online.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition, strongly supporting the nomination of Commissioner Madrigal Weiss for vice chair. She has always had an open door and been so willing to talk to people from the community. It has been noticed and it has been appreciated. She has been a stellar chair of the CLCC, and we just strongly support her continued role. Thank you.
And next we have online, we have Jamie. Your line is open.
Hi, I think Stacy stole my words. Hi, Commissioner Alvarez. It's been wonderful to see you again and everyone in the room. I know I've been away for a while, but I can't say thank you enough for you always being there for us as communities of color and being also hearing us as peers. It's not easy when you always coming from a culture that's always been silenced. And I really greatly appreciate you being allowing us to be a part of the discussion when we came to you with the challenges we face when, you know, culture, the linguistic and cultural stigma are barriers to our, to be able to have a voice at the table. Those are really a challenge for us when we come to the table as communities of color. And you always been there to help us elevate that and try to make it easy and make it so welcoming to be part of the discussion. And I continue hoping that, you know, we can all do this in a better way. And what more would be befitting and you coming to the role to be able to, you know, carry on the amazing work you have done before. And I look forward to connecting with you when you come back in December and continue the amazing work. And thank you again for being there for us. And we couldn't thank you enough. And thank you.
Thank you, Jamie. And I just want to clarify, Stacy was supporting Myra's nomination of vice chair and said my name. So just for the record, no, all good. Just for the record, I strongly support that as well. So we wanted to make sure that we got that right. So, okay, thank you so much. Myra, lots of support out there. So I just wanted to be sure. So, Jeff, I hand it back over.
Thank you, Madam Chair. Mariani, do we have any other public comments?
No, that was our last comment.
Anything else by commissioners? We have a motion and a second. We have a motion by Commissioner Tamplin and a second by Commissioner Bunch that Commissioner Alvarez serve as vice chair of the commission in 2024. At this time, I will read the roll. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Super enthusiastic, aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell.
Yes.
Commissioner Robinson.
Aye.
Commissioner Rolette.
Yes.
Commissioner Tamplin.
Absolutely, yes.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Aye.
I'm pleased to report that Vice Chair Alvarez has been unanimously elected to serve as Vice Chair again in 2024.
Okay, we are now moving on to agenda item 6, the items calendared for consent. This includes the approval of the Alcove Sacramento Innovation Project. Commission staff has sent the documents related to these projects to all commissioners at the time the November agenda was posted, and a copy of the staff analysis for Alcove Sacramento has been provided in your packet. As a reminder, any commissioner can remove an item on the consent calendar. That item would then be considered as a regularly scheduled agenda item at a future commission meeting. This project was shared with the public on October 20th, 2023, and again on October 30th, 2023. A total of 3 comments were received by commission staff during the final sharing of this project. 2 were in support of this project, and a 3rd comment expressed interest in working in partnership with Sacramento County. At this time, I would like to invite commissioners to offer comments or ask questions. I see no questions or comments in the room.
I would, Chair, Madam
Please.
Chair, I just comment, I spent a day at Alco convening earlier this year, and I think it's an extraordinary program, and I'll just leave my comments at that. Thank you.
Thank you, Commissioner Carnavale. Now is the time for members of the public to request to make a public comment on agenda item 6 by clicking the raise hand button on your computer or the app, or if calling in by phone, push star 9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, we would ask that you please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Amariani, please open the line. And do we have any public comments?
It looks like we do not have any public comments on this item.
Thank you, Amariani. So now that we do not have any public comments, I would entertain a motion.
Move for the recommendation.
Second.
See, Commissioner Brown made the motion. Who second? Thank you, Vice Chair Alvarez, for the second. We have a motion and a second. There were no questions or comments. I would ask Jeff that you please call the roll.
Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell.
Aye.
Commissioner Rolette.
Abstain.
Commissioner Robinson.
Aye.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Aye.
The motion passes.
Excellent, thank you. Next on the agenda, the commission will hear a presentation on the draft strategic plan for 2024 through 2027. I'd like to welcome Norma Pate. Norma Pate and Toby Ewing for this presentation.
Good morning, commissioners and community partners in the room and online. Thank you for your time today and appreciate it. Wanted to also thank Commissioner Carnevale, who's the lead commissioner for the strategic plan, and his support on this project. Toby will be participating remotely. He's not feeling well today, but he'll be online, and so he will be also presenting on this plan. As you're all aware, Californians are experiencing a mental health epidemic made increasingly acute by a global pandemic and strained workforce and diminished social safety nets for communities that need them the most. There have never been more funding and momentum to drive transformational change or such significant opportunities to advance new innovations in mental health treatment and delivery models. More work is required to reach the visionary system that the Mental Health Services Act intended to achieve. The strategic plan in your packets and posted on our website is revised, and today, Executive Director Ewing and I will share results from our engagement with community partners, reflect on our work over the last 4 years, and discuss future opportunities for the Commission. Next slide, please. Next slide, please, sorry. We are in the final stages of, I'm sorry, the next slide, please, Cody. We are in the final stages of developing the strategic plan. Staff developed this plan through public input sessions and interviews, and I'm happy to share recommendations from our engagement that support the Commission's commitment to reduce the negative outcomes of mental illness and promote mental health and well-being for all Californians. Next slide. And one more slide, sorry. Thank you. Over the last several months, staff interviewed commissioners and over 40 community members, facilitated 6 public input sessions, a focus group, and 2 surveys. I just wanted to take a few minutes to thank Kyla Mason, Callie Clark, Kara Starbird, Grace Reedy, and Lester Rabancho for supporting me and facilitating the public meetings. In your handout packet and posted on our website is a summary of results from our engagements and survey. This will provide you with more details on the feedback that we received and specific quotes made by our community partners. It is so important for me to elevate those voices, and we received so much feedback. It will be difficult to share everything that we hear today. We are continuing to analyze the feedback that we received, and we'll present more information in January. Next slide, please. As you recall, Boston Consulting Group facilitated 3 discussions at Commission meetings in May, June, and August, and the feedback received from commissioners and the public is reflected in the draft plan presented today. Next slide. Staff interviewed commissioners and received valuable information that is reflected in the revised plan. Next slide. Staff presented opportunities for community partners to provide input on the draft plan at the CFLC and CLCC meetings, and that information will be analyzed and shared in January. Next slide. As you are all aware, there is a strain on practitioners, resources, and consumers, and we invited partners across agencies and communities to hear their thoughts on how to develop effective strategies to improve positive behavioral health outcomes for every Californian. Next slide. Interviews and public sessions included individuals from diverse populations, marginalized LGBTQIA+ populations, and California communities of color face significant obstacles to receiving services. The draft plan aims to respond to these emerging trends by working in partnership to address systemic issues and advance innovation solutions. We invited individuals from diverse populations to help us build understanding of the potential to improve well-being for marginalized populations. Next slide, please. Over the last 4 years, the Commission has advanced the goals of the MHSA through 10+ initiatives across the lifespan. These initiatives have revealed the potential for transformational change and it was imperative for us to hear from our partners to better understand the needs of Californians across the lifespan. Next slide. Interviews with internal and external community partners shaped the Commission's core strategic plan and elevated the desire for a more focused set of priorities to help guide the Commission's time and focus. I want to take a moment to thank commissioners and all of our community partners for taking the time to answer our questions and participate in our input sessions. We can't thank you enough, and I just want to emphasize how much we appreciate you and your support. Next slide, please. Before we move on to the results from our engagements, participants encouraged me to highlight opportunities for the Commission to elevate 4 items that were important to the group: the DE&I plan, racial equity plan, and to focus on breaking silos, stronger feedback loops, and lifting community voices were all important to the groups that we spoke with. Again, we are still analyzing information, and I will come back with additional information in January to show how we included feedback in the plan, and if not, what we will do with the information that we heard. There were so many great ideas. Next slide. The first survey that we conducted that provided an opportunity for the public to provide feedback on strategic planning through the Commission's website. We asked participants 5 questions, and the data was pulled, and we received, 194 anonymous responses to our survey. The data was analyzed using thematic analysis to identify themes and patterns. Next slide. And we received feedback on core strengths and high impact roles of the Commission. Strong leadership and vision. The public felt that we have a vision for the future, long-term perspective, leads high-impact projects, and drives system improvement. Diverse and compassionate Commission membership, and the independence was important to participants. Advocates for services, serves as a voice for those with SMI and their families, convenes partners and listens, engages diverse communities, forges strong partnership and collaboration, promotes awareness and education, reduces stigma, provides vital information about mental health, and under fosters innovation, supports innovative ideas and programming, ability to be innovative and move quickly, tries new ideas, and creates statewide innovation initiatives. Next slide, please. For key areas of opportunities, focus on persons with serious mental illness and inpatient services was highlighted. Reduce number of people who are incarcerated and create additional beds in subacute facilities. Leverage data and standardized performance outcomes. The group felt that support counties and performance measurements and streamline data and collection for counties. Promote school mental health was also important. Prioritize funding and partner with schools. Build and strengthen prevention, suicide prevention, and early intervention efforts. The focus on specific populations. The participants feel that the Commission should focus on ADHD, address veterans isolation, and support aging population. Next slide, please. How can the Commission help shape the mental health system in California? Advocate for services and support legislation. Advocate for policy reform, funding programs and services, including housing and crisis services. Improve access to availability of services by promoting equity and access to services. Improve quality of services. Create statewide standards for care and treatment. Promote culturally responsive, evidence-based, and community-defined practices, and foster innovation and leverage the innovation incubator. Build and strengthen workforce, increase the peer workforce was important. Listen, engage, and empower. Increase client consumer decision-making and treatment. Use data to improve and inform. Improve quality of services and hold counties and organizations accountable. Educate and inform the public by increasing public awareness. Next slide, please. Priorities for the commission to consider was whole person healthcare integration and establish standards of care. Focus on parity and private insurance benefits. Next slide, please. And our survey also included an opportunity for our community participants to identify which areas they represent, and that's represented here in this slide. And one of the things that, looking back, we should have included specific marginalized populations, and we'll do so in the future because it doesn't really tell the story of the marginalized communities that participated. Next slide. We also had a strategic plan focus group, and in our focus group, staff asked 3 questions of participants. And the next slide, please. General feedback that we received is that we need to be more specific about who we are including in the term diverse, and provide local organizations with funding to improve community reach and visibility. Data transparency and sharing knowledge was key to building trust. Next slide, please. And for diverse voices, the group voiced populations that are overlooked in community engagement include LGBTQ, individuals who speak primary languages other than English, recent immigrants, and faith-based communities. There was substantial concern that the current efforts do not highlight intersectionality and identities, especially between race, ethnicity, gender identity, and sexuality. Accessibility was a noted topic, and providing information, easily understandable language, and easily obtained formats is needed. And there's also barriers to attendance to attend meetings. Next slide. How will the commission know when it's adequately engaged community voices regarding its strategic plan? The feedback that we received is to track the percentage of individuals who attend more than one listening session, push for greater data transparency on community engagement efforts to identify those voices that have not been heard. A clear recommendation from the group is to be more specific about who we are including in the term diverse, and to include this information in both the strategic plan and in our community engagement efforts. Next slide. Additional feedback, the group also voiced concerns about the decisions at the local level and would like to be included in the budget discussions and to include priority populations in the modernization plan as we move forward. Next slide. Last was our listening sessions. There were 10 themes from our listening sessions that are highlighted in the slide. And their expansion of peer support services. There's a need for more peer support services with an emphasis on aiding people with SMI and the unhoused, addressing mental health disparities, advocacy for better reflection and action on the needs of communities of color and specific mention of African American community needs, acknowledgement of LGBTQ plus youth and the requirement for youth-specific governance structures, policy and strategic planning, concerns regarding the translation of community-defined evidence practices into effective actions, cultural and linguistic humility, competency, enhancement of services reflecting cultural competency and appropriate language access, community engagement and trust, the role of the commission in enforcing community planning and reflecting public needs. Innovation and flexibility in treatment modalities, the potential of varied treatment modalities including peer support and spirituality for substance use disorders. Funding and resource allocation. Allocation concerns reflect a need for targeted delivery to underserved and unserved populations. Integrating services and holistic approaches, advocacy for recovery-based models and understanding the underlying causes of substance use, educational partnership and prevention, the role of schools and educational content in mitigating risks such as fentanyl exposure, and Commission's role and effectiveness with the final comment and calls for clear communication and demonstration of the Commission's accomplishments and future plans, the significance of aligning community voices with Commission actions. And again, more details are listed in the handout that's in our website, and there's also specific quotes that were received that were really impactful from our community partners. Next slide, please. As I mentioned earlier, we are still analyzing the data that we received, and we'll provide additional information on what we heard and how we included the information in our plan, or what we will do with the recommendations that were not able to address in the strategic plan. Next slide. That was a lot. I just want to thank you for your time today, and I'm happy to answer any questions you might have before I turn over to our executive director and discuss what's actually in the plan that is presented to you today.
Any questions, comments? So I see none. I'd just like to make a comment, Norma, and I've heard from community members, stakeholders, just what an amazing job that has been done really engaging the community feedback. And so I think that's of utmost importance. So hearing, being intentional about getting that feedback and building this out with them, I think is just awesome job. So congratulations to the team.
Thank you. I'm very
and the
passionate about
staff.
this, and I'm thankful for all the participants because it's important for us to all hear and for me to elevate those voices to you all.
Yeah, it shows. So thank you. Yeah, just wanted to say that.
I was just really happy to hear, like, the chair mentioned, like, the importance of getting community feedback. A common theme that I heard was, like, really uplifting consumers, peers, paraprofessionals. What were your thoughts on that? Is it, I mean, I think it's great, but just kind of wanted to hear what your thoughts were on that.
No, I think that that it's great that they're voicing those concerns, and that we want to look for opportunities. Our plan also includes internal appendices and for us to do internally, and two of those are community engagement and communication. So how do we further engage with our community, and that will be part of our plan, and elevate those voices, and then communicate what we've heard and what we've learned so that it's not lost. Because one of the things that really was highlighted is that when someone speaks and gives their thoughts, they want to be heard. And so we want to make sure that not only are we listening, but we're elevating the voices and making sure that those voices are heard.
And I kind of started to see some of that with the commission in their communications. Like, I've gotten an email, like aggregated, like, articles. So, I mean, I just appreciate this work, and it is demonstrated by, like, some of the new things that we're doing with communication.
Great. We hope to get better at it.
Oh, I love it already, though. I'm clicking on it.
Thank you. Mr. Ewing, are you on the line?
Yes, I am. Thank you. Wasn't sure if there were more questions in the room. Thank you. Thank you, Norma, for that outline. The bulk of that presentation, as reflected in the comments,
Okay,
was
hold on.
that.
Can we mute him, please?
Yeah.
Okay.
Sorry, Toby.
Toby, can you hear us?
No, he doesn't now.
He can't even hear us, huh? Okay.
Yeah, we can hear you. It's just there's echo with Toby again.
No, but I don't even think Toby can hear us. Because he's, like, blink your eyes or shake your head, Toby. Nope, he can't hear us, so. Yeah. Thank you, Commissioner Alvarez, but there's something going on, I think, specifically with Toby right now.
I have set off my sound so that I don't create the echo.
He hears it.
Oh, maybe he heard that.
Well, my sound is now on. Please advise me.
No, you're echoing terribly, so yeah. Sorry, Toby. Commissioner Alvarez, can we have you say something?
Sure. Can you hear me okay? I can hear you.
Yep, we hear you perfectly. So, thank you. I wonder if they hear her fine. Is Itai still on? Oh,
Yes, I'm still on.
okay, and do you hear Myra fine?
Yep.
Okay, so let's try this. Should we-
The echo was limited to Toby.
Toby, yeah, okay. Thank you. Tell us when we should try Toby again. Tom, will you tell us? Oh, okay, that's not going to start a problem.
Test, is that better?
No.
Test, is that better?
Yeah.
Much better.
All right, staff remotely accessed my computer and clicked and unclicked a dozen things that I didn't understand. So I'm glad that worked. So again, thank you. Thank you, Norma, and to the whole team. I think as you heard, we have really tried to create some robust opportunities for community engagement around the strategic opportunities that the Commission has in its role as a state agency and as a member of this broad mental health community. And I think we're really learning lessons from the last time we did this, really trying to understand how we can create pathways for public engagement that will serve both the strategic plan, but also the Commission's work moving forward. And, in response to Commissioner Chambers' comment, we're also working on a visual representation of community engagement that will help the Commission, our team, and the public understand where we have been engaging across the state in terms of geography, but also in terms of different community organizations, different levels of government, different levels of, or different types of community organizations, to really mostly help us understand where we need to do better. And, the harder challenge, as Norma pointed out, is to ensure that the information that we're gathering in that engagement is reflected in the work that we're doing. And so we're, per that media report that was shared, we're also, Andrea Anderson, our communications chief, has this phenomenal team that is really working to make sure we get better at gathering information and sharing it with you and the public. So thank you, Norma, for the work. And thank you, Andrea, for the work that you and your teams are doing. If we could go to the next slide, please. Just wanted to kind of circle back and remind you a little bit of some of the opportunities we have as a commission. And so, we, as part of our engagement with the public, as part of our listening to commissioners and others, just wanted to highlight some key points of inflection around how we can improve California's mental health care system through this prevention and early intervention lens, by really championing innovation, that those two areas of investment need to reflect culturally competent and linguistically appropriate care. In other words, care needs to be tailored to the needs of the people we're serving. Inequities and disparities, major driver of the work that we're doing. Collaboration is what it's going to take in order to be successful. And the focus really needs to be where services and policies and decisions are made, which is typically at the local level, supported by policies and practices, funding, and other decisions that happen at the state level, on the commercial insurance side, and at the federal level. Next slide, please. So, we do have some really emerging themes that we want to flag for you. And these themes really reflect the fact that our mental health landscape is evolving very rapidly. That evolution has been accelerated because of COVID and greater public understanding. And so we have some opportunities to leverage that. But these 5 themes really are emerging. One is that there's a tremendous appetite among the public and policymakers for a better understanding of what we mean when we talk about mental health and well-being, and a better understanding of why that's important, and how inadequate access to care creates challenges that are impacting individual lives, families, and communities, but also that have profound fiscal impacts on the state and local governments. And so there are, multiple bottom lines that we can improve when we do a better job responding to needs. Behavioral health is, as you know, has been elevated as a shared priority. When we started this work, the voices that were in the room were typically clients and family members and providers. And increasingly, the number of advocacy groups that are focused on behavioral health is growing tremendously. The number of allies that are available to support peers and family members has increased. We see that through our work in mental health in the workplace, through the significant investments that the governor's made in school mental health. So behavioral health is really being elevated as a priority. There are some incredible evolutions in care delivery, but also strains on practitioners, resources, consumers, and families. And one of the biggest takeaways is just the pace with which change is happening. That is both very positive because the needs are so profound, but it can also be challenging to stay on top of what's happening and to ensure that change is headed in a positive direction. Next slide, please. So the Mental Health Services Act, again, was really designed to transform outcomes in the behavioral health space. And these 7 negative outcomes were elevated in the act. So suicide, justice involvement, educational success, helping people find employment to support recovery, reducing the number of people who are unhoused, keeping families intact, and this, the most ambitious, this goal of eliminating prolonged suffering. Next slide, please. So the strategic plan that we're working toward really has these 6 core strategic building blocks. And we're working to seek clarity from you and through this consultation process on vision and mission, our guiding principles, the role that the Commission plays in this vast behavioral health landscape in California, in the country, in the world. Based on those roles, the strategic priorities that the Commission identifies, key initiatives that we'll pursue within those priorities, and then how do we leverage our skills, our staff capacity, the things that we do well, our expertise that falls under those capabilities in order to drive the kind of outcome we're looking for within those initiatives. And so the next slides really flesh out these 6 building blocks of the work that we're trying to build into the strategic plan. Next slide, please. So, this is the draft of the Commission vision language that has been developed through the consultation process with individual commissioners, through the public consultation. It's still a draft. right, we'll bring this language back to you. You have it today, but today is more about a report out. That there will be opportunities to comment on this today, individually, and then early next year we'll have a full draft that we hope will be ready for a vote. But the vision that we have in front, all Californians experience well-being through a coordinated system that prioritizes prevention, early intervention, and recovery-oriented services, builds on the strengths of communities and marginalized groups, and creates opportunities for individuals to engage in meaningful and purposeful activities that help them to thrive. And that vision is really designed to be this very positive driver of our opportunities to thrive. Next slide, please. Remember, these are these 6 building blocks of this strategic plan. And so within that vision, the team has developed this mission statement based on the consultation process that Norma referenced. The Commission works to transform systems, so heavy emphasis on systems here, by engaging diverse communities and employing relevant data to advance policies, practices, and partnerships that generate understanding and insights. So that understanding and insights is that comment that we shared with you earlier about these key themes of improving understanding of what mental health means and the impacts that achieving good mental health outcomes has. So generate understanding and insights, develop effective strategies and services, and grow the resources and capacity to improve positive behavioral health outcomes for every Californian. Where this statement has differed from some of the conversations we've had in the past really is this focus on systems level work because of the impact that will have on the individual services that California is able to provide, and the outcomes achieved for Californians. Next slide, Cody. So our guiding principles and core values, right? 2 of those pillars reflect these aspirations. And so strengthening collaboration, it's that outreach and engagement, really having tailored and culturally competent services, accessible, affordable, high quality whole person care, partnerships essential to be successful, and then innovation and continuous improvement in learning are part of this system that will help ensure that we're progressing constantly throughout this path that California is on. I'll give you a little bit of time to look at the language on this one rather than reading all of these. All right, next slide, please. So the Commission's role in this endeavor, again, we are within state government, and we work with public, private, and civic partners to really drive this system level improvements. And part of that is, building that understanding, as I mentioned earlier. Part of that is how can we incentivize, accelerate, scale best practices. There are phenomenal programs in California, but oftentimes we find that these successes don't scale very well. They don't get replicated. The Commission has played a very strong role in supporting innovation to really create space for county and community partners to try new things and to learn from them. We think that continues to be a very important practice, and to do the accountability and oversight that is important to help the public and policymakers understand where we are in terms of our ability to deliver the outcomes that the public are looking for in the context of those well-being statements that we shared earlier. So it really, at this point, we're really trying to leverage these 4 key facets of our work and think about how each of those can be deployed in the areas that you identify as priorities for staff to deliver on. Next slide, Cody. So where are we at the moment? We have multiple initiatives underway. We typically share that with you, and we remind you of that. We share it with you throughout the year, but in January during our budget presentation, we tried to give you a broad overview and a reminder of all of the things that are in our portfolio. We tried to do that again at the midpoint of the year as part of our budget report out. But currently, with direction from the chair and the full commission, our youth mental health work is primary. Some of that is in school mental health. Some of that is built around our suicide prevention efforts because of the incidence of youth suicide. Some of that is our youth empowerment work, our alcove work, early psychosis and suicide prevention. Much of that is for young people, but it's not limited to young people. Integrated community treatment, and that includes, and that's such a cross-cutting statement, but it includes our work around workplace mental health and school mental health and psychosis. And then we continue to work on criminal justice intervention, particularly through our psychiatric advance directives work, our efforts to improve how counties understand the ways in which mental health clients and families become involved with the criminal justice system, and how can we create off-ramps through this, what's often known as the sequential intercept model, to reduce justice involvement. So some of these priorities are dictated through legislation and the budget. Some of them are as a result of direction that the commission has given us. That does make it a little bit challenging because the work that we do needs to be informed by our strategic plan and determined by the commission. Sometimes we get direction in a rather short term through the budget process from the governor and the legislature. And so we're really trying to find that balance between a long-term strategic vision and our need to be responsive to policymakers as they make their decisions. Next slide, please. So for 2024, for the next 3 years, what we're really trying to understand here is, what will our operational priorities be? And I would say these are sort of placeholders at the moment because we want to make sure we hear from commissioners in the community and get this right, and that these decisions are made in the context of budgetary resources and staff resources that we have. But the North Star priority, what's really coming out of the conversations we're having with commissioners, with work groups, and these public forums and these surveys, is to really advance early and effective universally available services, right? To really look through this population health lens, but translate that into the kind of care that individuals have access to, particularly through prevention and early intervention, and that it is done in a way that is tailored to all Californians. And so that North Star priority we're trying to capture in this very tight statement: advance early, effective, and universally available service. Operationally, what we have at the moment is that we'll work to increase the pace and scale of these improvements by building a stronger foundational knowledge, creating that awareness that is necessary to guide the decisions that the governor and the legislature, that local agencies, that community partners, and others are making about how care is delivered in California. Typically, those aren't decisions that we are making. What we're trying to do is to build that foundational knowledge to inform the decisions that these other partners are making, and to do a better job recognizing the gap between where we are today and the opportunities we have. So close the gap between what is being done and what can be done. And that's really about scaling effective practices. So, part of the conversation that Stacy raised around community-defined evidence practices, right? There's a huge demand for more of what works. And so close the gap between where we are and what we know can be done. But this third bullet here, close the gap between what can be done and what must be done, is really recognizing that we also have to address some of the gaps where we don't necessarily know exactly how to do that. But we recognize that the problem has to be addressed. And so while close the gap between what is being done and what can be done is more about scaling and ensuring that best available practices are being used, as in the example of early psychosis care or full service partnerships, we also want to recognize that there are some gaps in our knowledge around how we can improve outcomes beyond current best available practices. And this is where innovation, this is where research, this is where the Commission's power to convene really can begin to push and drive the kind of transformational change in the areas where we don't yet have clear guidance on what should be done. All right, next slide, please, Cody. So, one of the things we're constantly looking at is what are we good at? And this was referenced in Norma's comments, through the survey work where we've asked the public, we've asked you all, we've asked other partners, where do you see us? What do you see as our strengths? What do you see as our opportunities? And so really driving policy, driven by research, public engagement, and leveraging what we're learning through these site visits and through these community engagements to really shape and guide policy. Driving practice, the fiscal incentive, something that is on your, next on the agenda, the technical assistance, and using our data to drive decision making. And then using that to really look at system performance and systemic opportunities for change, which is often about helping our partner agencies in state government, at the federal level, at the local level, recognize some of the opportunities that we've been able to identify through the engagement, through the learnings that we have supported. All right, next slide, Cody. Through the work of BCG, our Boston Consulting Group, we asked them to really help us think about how we make decisions. And this issue has come up over the years from members of the public, even from commissioners, particularly new commissioners. How do we make decisions about where to invest? And so, we had asked BCG to, tap into their expansive knowledge network, to look at the history of the consulting that they've done around the country and around the world, and to help us think about how do we make strategic decisions for where we dedicate resources. Again, some of those decisions are made for us through the legislative process or through the budget process, but the commission does have significant discretion. And so, this graphic of really thinking about how we can be strategic in terms of the resources that we have. So, what needs are we trying to address? What impact do we expect to have on the behavioral health system through the lens of disparities, through the lens of efficacy, through the lens of the kind of outcome that we hope to achieve? Is taking on a new project or a new initiative, does it fit within who we are in our portfolio? And how feasible is success? We're still working to translate these 4 layers of decision making into tools that will make it easier for us to make informed decisions. But what I want you to see is that through the consultation with BCG, through the discussion with each of you, and through the community consultation, we're really trying to get better at making well-informed, realistic decisions of what expectations are in terms of the kind of outcome and impact that the work that you authorize will have for California. All right, next slide. So to sum this up, what we've drafted here as goals and objective for 2024 through 2027 would be to advance this vision of well-being for all Californians through playing this champion role from driving from vision to action, advancing best practices, inspiring innovation and learning, and being relentless in our push for improvement. And so, and that includes creating some uncomfortable conversations. And I really appreciate Sheriff Brown's comments. I was not able to attend the trip up north, but I really appreciate that Sheriff Brown commented that some of those conversations are uncomfortable. And I think that is part and parcel of this notion of being relentless in driving improvement. We have to be comfortable being honest about where we are and where we need to be, and the consequence of that gap, and what it means for individual Californians and then California collectively. One more slide there, Cody, before the last one. So our next steps is really to, we've given you this draft and this chance to chat and give us some guidance. Our goal is that we'll work over the rest of the year and be able to give you a final draft in January for deliberation. That's not the last time you can talk about it. Certainly that's just the next opportunity. If we didn't get it right, we need to hear that, and then we will continue to work on it until we get it right. And the last slide simply says thank you, and happy to answer any questions you might have.
Thank you, Toby. So are there any questions or comments? Please, Commissioner Gordon.
Yeah, I just have a brief comment. I think this is very, very well done. The 2 things that strike me that need to be amped up is the two biggest issues that we're seeing from all of the work that's been done with schools and is number one, the question of access. Access is different from availability because availability means somebody is sitting somewhere waiting to serve you. Access is when you're in a setting where you have the relationships to get yourself somewhere that you trust to access those services. So that's number one. The second one is early intervention. And again, I worry most about the 0 to 5 space where we have lots of medical care and attention and screenings supposed to go on. If they do go on, we really have a roadmap to prevent many of the things that happen when kids get into preschool and TK and kindergarten and so on. What can we better do in that space to make sure those screenings actually happen and there's an ability to work on them with families in a way that will forestall a lot of the things that will happen to young people in the later years. So. And those are not easy issues, but I think that's what we're feeling are sort of the heart of the matter.
Yeah, absolutely agree with you. Commissioner Robinson also wanted to make a comment. Please, Commissioner Robinson.
Thank you, Chair. I was going to say exactly the same, some similar comments about access. And in fact, we call it out as our North Star. I would think a word or concept like access would even be in our vision statement. So let's think about, putting it out there and elevating it to that status because it's such a critical issue that I hear about consistently. Two more comments. One is a question, I guess. For my edification, when we say all Californians, does that exclude like undocumented migrants? Are they eligible for services? And so I think when we talk about, in our vision, all Californians, I just want to make sure we're inclusive of groups that we may be just even verbally excluding. Just a thought there. And then the last comment, and I don't see this much in the strategic plan. It's one that I see a lot in my business, and it is the concept of getting people or patients to the right setting as quickly as possible. And when I'm talking about, and maybe it even ties to access, psychiatric patients who end up in emergency rooms for hours, sometimes days, particularly kids, also behavioral health patients that find themselves incarcerated. So just the concept of getting patients to the right setting, I think needs to be amplified in our strategy.
Thank you, Commissioner Robinson. As far as all Californians, I think it's always been the spirit of this commission to be inclusive of all Californians. So at least has always been my understanding of, yes. And as far as the other points, Toby, I hope you're taking note. I'm gonna call on, do you want to go per commissioner's statement, or should we go to Commissioner Danovich and Vice Chair Olivares, and then you can comment to all? What would be best, Toby?
I'm happy to take them one at a time. And so on the Commissioner Gordon's comments.
Maybe, Toby, since there's so many of us and we're going to all have things to say, maybe it makes sense to hear them all out. You can address common themes. Sorry to jump in there. I just didn't anticipate that there's going to be a lot. I just want to say, first, it's a great plan, and really appreciate all the work that went into it and echo the comments that have been made. A process comment is I see the breadth and compelling nature of our vision as one of our big challenges, which is that our vision has an almost infinite scope to address the mental health needs of all Californians, and is the vision that should be there. I think it creates a challenge for our ability to execute and our ability to focus. So I think the decision-making approach framework that's in the strategic plan is really, really important because we need to be effective. And to be effective, we have to focus and we have to pick and choose things, which means that we have to defer other things that are really important to us. And I want to make sure we remind ourselves of that because it means we each have to give up things that we want to do now for the sake of other things that we want to get done effectively. I think that also related to that, something that I've seen over my tenure with the commission now that has really been a part of the commission's success has been the strength and talents of commission staff. And I think that a major tactic that we need to continue to be thinking about, and whatever happens with the nature of the OAC this year, next year, is investing in our staff to cultivate their own ability to continue to learn and to grow and to be able to execute on the directives that we give them as a commission. I think we could probably give more explicit focus to how to do that towards our goals of being effective at whatever are the many priorities we choose to take on. So thank you. Those are my comments.
Thank you, Commissioner Danovich. Vice Chair Alvarez.
Thank you, Chair Madrigal-Weiss. And my comments actually piggyback off of Commissioner Danovich's comments as well, a little bit more related to process. I think all of us truly believe that a strategic plan is more than a plan that sits on a shelf and has some sort of action-oriented agenda to demonstrate our commitment to this plan. And so similar to what his comments were, the commissioner talked about the strengths of commission staff. And I'm curious if there's an opportunity to do some sort of a crosswalk with commission capabilities that we do have, whether it's our staff, our committees, our current projects, because to your point, Toby, we are doing a lot of this work now. And so what are we building on versus what are we looking to bring on as far as capacity, again, in order to fulfill an action plan that corresponds or goes along with this strategic plan to demonstrate what we are doing, and also so that we as a commission can track our progress towards that. What are those major milestones that we want to meet, and how can we ensure that we're doing that in collaboration with the capacity that we've identified, and then with the new tools and resources that we're bringing on board. So again, that like crosswalk or capability assessment as part of this work.
And Commissioner Rolette, please.
And one of the unique operational challenges that I sometimes encounter with strategic plans is developing impressive documents that don't do anything. And it is a very impressive document. And that would be my first process comment, that we got to make sure that it does something. And that would be my second process comment, when the breadth of the document is so daunting, it can intimidate and alienate commissioners, the audience, the public, and that's when it sits on the shelf because it's just so impressive. We don't know what to do with it. And there are components of the plan that I think could be accomplished by virtue of the suggestions, and again, I won't repeat them because I won't do them justice, that the two previous commissioners just made, that would be helpful for me because, again, I certainly believe that, as an example, engagement is a critical component of what we do. Prevention and early intervention is a critical component for what we do. Advocating for the stand-up of CDEPs is a critical important component of what we do. And a crosswalk that showed me as a commissioner what my role could be in advancing some of those critical components as a part of a strategic plan would be helpful, because in conclusion, I want actionable steps. I want things that you want me to do to help you to advance this plan. It's like being a great ambassador for a wonderful document, but it ultimately would end up sitting on a shelf. Will you want me to be an ambassador for action?
Thank you, Commissioner Rolette. Toby, I don't see any other hands, sorry, any other hands raised for comment. So if you want to respond at this time, please.
Thank you, and I and I apologize that I'm not there with you. Norma very appropriately pointed out that one of our roles is to address stigma and to create awareness. I am home with COVID, and so my stigma busting here is to say this illness is still circulating, and be wary and take care of yourself. So I apologize I'm not there. I should have said that at the beginning of the meeting. I think the comments from commissioners really reflect where, what we're hearing from the community, this tension between trying to tackle the myriad challenges in California's mental health system and trying to be effective at a handful of things that we're good at. Today's discussion is about us taking notes and listening and being able to respond. As Norma said, we are working on 4 sort of operational plans that come out of the strategic plan around community engagement, communications, data, operations, and personnel. And so, our goal is to have in January a refined version of this for you. It may take us longer than that to create the operational strategies, but just Commissioner Rolette sort of captured many of the comments from commissioners to say, how are you going to make it real? And so that is absolutely our goal. As Commissioner Danovich points out, the tools, that decision-making tool that we gave you a very pretty graphic of, it's not designed to sit on the shelf or on the wall, but we have not yet figured out how to actually bring that decision-making framework into discussions with you each year. But that is our goal, particularly through our conversations with you around our budget and our staff capacity. And so we hear you, we agree, and we'll bring you back some specific ideas that look like that crosswalk that you're asking for. So thank you.
Thank you, Toby. Any other comments, questions? So I think it's
just real quick.
Please.
I want to I appreciate the vision. Like the vision and mission, I know that's pretty broad, but for me, the vision has to be inspiring, has to give us that, again, reason why in your strategy to advance transformational change, that slide 30, where it takes us through the steps. The vision and mission is really important, and I want to just express that I appreciate that it has, again, the why we're here, and whoever's struggling with mental health issues. And right now, lately, it's been a lot of Californians, right, across. So the goal of supporting well-being as a vision for all Californians and supporting recovery-oriented services, it aligns with what we're about, why we're here. So I think that, really does capture it well, and the staff and team did a good job in that, and the mission. Two, I think where we're gonna, I'm hearing my fellow commissioners and everyone share is like, when you get down to the priorities, and specifically the operational priorities that I'm looking at on slide 35, they're pretty, getting into the details of what that gap is will give more clarity of where our energy and focus goes into, because the gaps, there's a lot in each one. So that piece, I know we'll be working together, or you all, and I'll be following what you're doing. But I just wanted to share that. I do hope that it continues to uplift, well-being and recovery for all Californians, because that's, I think, why we're here. Thank you.
Thank you, Commissioner Templin. So it's also my understanding, Toby, then, that we'll continue to have conversations around this. I particularly, appreciate, yes, the beauty of it, of course, want the functionality of it. I particularly appreciate the decision-making approach, slide 37. I think since I've come onto this commission, it's how do we make the decisions? And sometimes it seems like a commissioner who has a great passion and will just bring something up over and over and over, and then it's like, okay, that's what we're going to go with. So to really have a process is something that I think we've been looking for. So this is probably the greatest, the most concrete I have seen a process. And so I like that we're getting to that, where we can really run through very specific questions. Is this around, is this the impact, the fit, the feasibility? So all of that, I appreciate that we're starting to come to that. And our capabilities, I have seen as well how we do drive policy and practice. And I think the greatest and most present example of that is the MHSSA, activity that we're doing right now. We're influencing mental health in schools in 58 counties at once, which it has never been done before in that way. So I think it's just really powerful. So appreciate this. Thank you for presenting today, Norma and Toby, and for letting us know that we're going to have continued conversations. It doesn't end here. It's just the first stage. And for hearing what all commissioner input. So thank you for that, Toby. And with that, we are going to go ahead and move on to our next agenda item, which I'm sorry, no, we're not. I skipped a whole piece. I'm so sorry. Public comment. I'm sorry. Okay, so at this time, we are going to, now's the time for public comment. So, and on agenda item 5, please raise your hand on your computer or the app of calling in *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, please limit your comments to 3 minutes or less. Mariani, are there any public comments, either in the room or online? So please raise now, so the queue will be closing.
About 7 public comments. We have 1 in the room and the rest online. In the room, we have Stacy.
Hi, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. First, again, I want to compliment the staff and the contractors for a very good, I thought, public process. I really feel that people had opportunity, and I feel like they listened, because I remember making one small comment about changing the word because you had minority instead of, that's kind of an old term, and they changed it. So I feel like I'm being heard, so I really appreciate that. Regarding the actual plan, I made comments on the last preliminary draft. So in your packet, the page 10, I don't know if you looked at the goals and objectives, but interestingly, the goals and objectives on the previous plan were much more specific. And although I had comments on those, these on your page 10, the goals and objections, the champion vision to action, advanced best practice models. So I guess I'm not sure what prompted the change to go to something more general. I'm just, if that is what the commission wants, it's just that I think this other one from the last time, where you actually had, for example, objectives, evaluate the impact of innovation interventions, catalyze and support scaling of local innovations through capacity building. And I was going to put, because you talked about full-service partnerships, uplifting CDEPs, you know, I wanted to add that. But with this general one, it would be difficult to do that. And you had engage, for example, under build public trust and ownership, you had the objective, engage individuals and families with lived experience and elevate their voices and needs. And I was just going to add with a priority on communities, on BIPOC and LGBTQ communities. But these are quite general. So I'm not trying to criticize, it's just, it's to me, unless, I know Toby talked about operational strategies, and maybe you're going to do a whole nother sheet on, or no, you know, you're going to specify operational strategies under these goals and objectives. But anyway, and then I just wanted to please say on this chart, which community do you represent? I just really hope you do put racial, ethnic. You have LGBTQ, but you do not have racial and ethnic communities. And I really feel that that's important to know if we're getting the underserved communities. And I do want to compliment, I actually really like the commission vision, the guiding principles.
Thank you, Stacey. Your time is up. Please wrap up your comment.
Okay, are excellent. It's just that when, again, we get to the actual things that you're supposed to do, sort of as Commissioner Rolette was talking about, what are you going to do? Then it kind of got all general, and then mentions of underserved racial ethnic communities were gone. But anyway, great job. Thank you for letting me comment.
Thank you, Stacy.
Next online, we have Richard. Your line is open.
Good morning, Commissioners. Richard Gala from Santa Cruz County. I wanted to say regarding the online surveys, I'm disappointed that the numbers is low. We need more, and I think it's important to collect more because you need to hear more from consumers, peer workers, and families in particularly, because they're the important groups to what's happening, what's not happening, what's not working, etc. For the two commissioners that mentioned regarding the 1 to 5 age group, they are being provided various services by the counties through the state-funded program called First Five. So that's an initiative that's been working on serving that target population. Just for the commissioners to be aware of that age group is being captive. I was in a county meeting last week to remind them serving children with disabilities to be part of being served compared to the non-disabled population when it comes to parents that don't have children with disabilities. Far as Toby mentioning regarding letting the counties do their own thing, I totally disagree with that. It's continued to happen, that has happened with the MHSA, where you have directors that do not have the buy-in with the community planning process. San Diego County is one of them, Santa Cruz County is one of them, and there are a lot of other counties throughout the state. That's an issue. It's not being driven by consumers and families to make those plans, to have those plans. I think the oversight commissioners need to have some hands-on to not continue to fail as it already has been over all these years. You cannot have hands-off, giving them the dollars and then walking away from it with no hands-on. Counties have failed to not follow the needs of the mental health community in their community when it's more in the old ways before the MHSA was enacted. Let me as a director decide what programs we'll have and what programs we won't have. I don't need community's feedback. This is part of the problem with the counties. We don't have their buy-in, and the commission and the staff needs to get that. It's a fact, it's a reality, it's a problem. The Modernization Act, the Oversight Commission needs to vote against this. I know that you guys voted for SB 326. This is less funding for counties. If it passes, this does not look good for the peer workforce with less funding for the
Thank you,
peer
Richard. Your
workforce
time is up.
and
Please
the
wrap up
current
your comment.
programs in service. Yeah, I'll finish it. I'll finish it. With current programs are being funded, may be significantly reduced or eliminated because that funding is going to be gone if this legislation is passed. Peer workers can be part of the workforce with the Oversight Commission to help you achieve those goals, achieve those tasks, achieve those challenges that you're facing. We can be part of your group and helping you make those successes happen, those improvements happen. Thank you.
Thank you, Richard.
Next, we have Andrea. Your line is open.
Hello, Andrea Crook here, and I just want to give a shout out to Norma and Toby. That was an excellent presentation. I have to say that the presentation that you provided, Norma, where you were finding an overwhelming response to wanting to increase our peer workforce and support our unhoused, particularly African American population that is disproportionately represented in our homeless counts, is something that we're seeing here in Sacramento. In fact, we have an innovation plan that we have developed around this direct population with this type of response for that population due to the unprecedented numbers that we have seen and the community response. So I just want to say it's right in alignment. And I agree with Commissioner Roulette that it's an amazing, resource and data to have, but now the work begins. So I know that we look forward to lifting this up and working with you to move this forward and find solutions together. So thank you.
Thank you, Andrea.
Next, we have Jerry. Your line is open.
Hi, everybody. Good morning. I'm Jerry Hall from San Diego, a former BHEB member. And I too really appreciate the work, and I can see some a lot of the things that I care about being reflected in here and in the comments from the other community members and stakeholders. And my biggest concern, and I hate to sound like a broken record, but is also the community program plan. And this is the only thing in the duties that a Behavioral Health Advisory Board is required to approve. And it's the plan that the county is going to use to engage the community meaningfully throughout the year on an informed basis. And of the 5% that is funded or provided as an allowance to counties, only 8% of that funding was used in fiscal year 21-22 by about half the counties. The other half the counties did not report any CPP expenditure. Now, we all know they're planning, they're just not creating a plan on how they're going to plan, and they're not getting that approved by their boards. I have yet to find a county that goes to their board with a plan and asks for approval. In my county, the last CPP plan we came up with was in 2005, before Twitter was born. So we have an engagement plan before one of the biggest social media vehicles was made available. Public engagement, I believe, is the most underutilized tool available to the county behavioral health systems, and more importantly, to community stakeholders and each other. The community engagement results in the report show repeatedly that people care about being engaged and about being transparent. I think the one solution could be I urge the commission to identify and specify the CPP as a key focal point in the commission's work and in their strategic plan. So over the next 3 years, we are building a truly engaging engagement process in each of the counties, and that each of the counties are being held accountable to ensure that they're including stakeholders. it's a beautiful tool, but it's unable to we're unable to really see things through if we're giving feedback and we see our comments being included, but then we see the behavioral health systems doing what they wanted to do on their own without our feedback. So I don't mean to go in circles, but I do believe the CPP is the most underutilized tool, and it's something that you could effectively support because it's already legislated, funded, it's just not being used. Thank you very much.
Thank you, Jerry.
Next, we have John. Your line is open.
Hi there, commissioners. I wanted to apologize for not being on camera with you today. I myself am recovering from the flu and still not feeling 100%. Just wanted to keep my comments brief, knowing that this is an ongoing process. Want to align my thoughts with Commissioner Roulette's comments. We at CBHA, the California Council of Community Behavioral Health Agencies, look forward to seeing an operationalized version of this plan. Our members and community-based providers stand at the ready to continue helping the commission and elevating the voices of people receiving services and the voices of those that are responsible for delivering them in communities. So just wanted to say thank you for the presentations today. Looking forward to seeing more as it develops. Thank you.
Thank you.
And that was our last public comment.
Excellent.
Can I just add one clarifying? So the goals that were presented today include the feedback that we received from commissioners and the public. And so the next plan that we'll present will have the objectives that will provide more details on those goals. So they're still changing, and we're taking everyone's comments today, and we'll include that feedback in the next version.
Perfect. Thank you so much, Norma. Again, Norma, Toby, thank you for presenting today. And any other questions, we will reach out. So excellent job. Thank you. So at this time, we are going to move on to agenda item 8. The commission will consider allocation of $20 million of Mental Health Wellness Act funds to support programs that advance substance use disorder treatment and that reflect the diverse needs and populations of the state. As you may remember, our September commission meeting included a presentation on opportunities to allocate Mental Health Wellness Act funds up to $20 million to support substance use disorder treatment efforts. And Commissioner Danovich has been working with staff to identify the best approach for the allocation of funds. Before the presentation of the outline, Tom Orrick will be presenting. I would like to ask Commissioner Danovich if he would like to say some words about what has been learned between the September Commission meeting and today, and about opportunities to support improvements to substance use system of care. So Commissioner Danovich, please.
Great, thank you. And thanks for the opportunity to present to you all on this and to introduce Tom, who's going to get into the details. Let me just say at a high level that, coming off of this discussion of our strategic plan, to achieve our vision of recovery and well-being for all Californians, we know that we have to address all of mental health, which includes substance use. We know that treatment for substance use disorder works at least as well as treatments for other chronic health conditions. However, most people don't have access to it, and it's often separate from delivery of mental health services and medical services in a way that that our friends and family members and the many people in our population that need services ultimately slip through the cracks and don't get what they need. California, our state, has made a lot of commitments to improving care, improving the standards of care for both substance use disorders and for mental health. And we know what needs to happen. However, the pace of change is slow. There's tons and tons of barriers that get in the way of making the change that we know needs to happen. There's misaligned incentives. There's issues with the workforce and availability of adequate workforce. And so a lot of our opportunity as a commission trying to achieve transformational change is to figure out lever points to accelerate transformation in the system. Ideally in areas where the system is poised to change but needs a little bit of help, needs incentive, needs grease on the wheels, needs something to help move things forward. So the charge to staff in developing the outlines of this initiative was really to develop a feasible and focused plan to accelerate improvements in the substance use specialty care system. And this is because, for reasons that I won't belabor here, you all know, historically, the Mental Health Services Act focused on mental health to the exclusion of substance use. And so this is an area where we have not had focus and attention. So recognizing we can't address all of substance use issues in the way that I would love to, we wanted to be focused and to ensure that we develop a plan that's feasible, and that ideally we support an area that touches on the problems of people slipping through the cracks, which is how to integrate services so that people receiving care for a substance use disorder are also receiving care for mental health, also receiving general health care. So our staff, under Tom's leadership, did a phenomenal job of engaging with a diverse group of stakeholders, people in recovery, providers on the front line. Many of you participated in the site visit that was done in Los Angeles, with state leaders, with county leaders, with subject matter experts, to bring you the rough outlines of the proposal that you're going to hear to make a decision about directing funds in this direction. So with that, let me turn it over to Tom to present to you a little bit more detail about what we have in mind.
All right, thank you, Commissioner Danovich. For this presentation, the outline is in your packet, and you also have the PowerPoints in your handout packet. And then, to tie this item in, building on what Commissioner Danovich just shared, but to tie this into our last discussion about strategic plan, I wanted to highlight the comment from Commissioner Gordon about, access versus availability versus access. And I think that's what we're really trying to move toward with this initiative. Our hope with it is to increase access to treatment where people are providing services, where they are and when they need them. And then Chair Madrigal-Weiss' comment about the MHSSA is an example of what we can do, what can be done. And I just wanted to point out that in 2017, that was a $20 million investment of SB 82 funds to launch what we've done with school mental health way back then. And it's just interesting that this is also a proposal for a $20 million investment that we hope will spread change, much like we've seen in school mental health over the last several years. So, as we all know, substance use disorders cause havoc in people's lives. The disorder robs people of their futures and their opportunities, and it often separates people from their families and their children. 6,000 Californians died of opioid-related overdose in 2021. And if it isn't the leading cause of homelessness, it's got to be a close second. So there's obviously a lot of work that needs to be done and needs to happen to improve coordination and improve outcomes in this area. So over the last several months, Commission staff, with the guidance of Commissioner Danovich, have been in meetings with experts in the field and boots on the ground staff to determine the best way to allocate $20 million in Mental Health Wellness Act funds. So I'm happy to present this plan, which we think aligns well with the Mental Health Services Act by providing health, mental health, and SUD services in a more integrated and coordinated way. This plan also creates a learning network that has a great opportunity to continue to inform the Commission's work in SUD and put the Commission in position to advise the legislature and the Governor's office on best practices and support the ongoing work of the Department of Healthcare Services on into the future. So I'd like to provide an outline, an overview of the steps taken to arrive at the proposal, and then present the plan, and then share how the proposal can help us to raise the bar, as Commissioner Danovich has encouraged us to do. So before I present the outline, I'd like to provide a brief background of the availability of the funding for the Commission's previous work in crisis early intervention and crisis response. So Senate Bill 184 amended the terms of Senate Bill 82. This was necessary because the first two rounds of Senate Bill 82 funding revealed that counties really lacked the workforce to pull it off. The grant at that time was limited to be a personnel grant. They were able to use the funds to hire staff. Well, without staff, many counties didn't hire to the level that they thought they could. And so 184 amended that. It amended now how it now allows the commission to support prevention and early intervention. We can now incentivize change through both competitive procurements and sole source contracts. And the funds can support a wide range of grantees, including behavioral health departments, but also hospitals, schools, community-based organizations, and other organizations. So in response to the new flexibility, the Commission set 5 priorities to expand the number of empath hospital-based CSUs. These are crisis stabilization units on the grounds of a hospital. That has happened. To scale programs to support older adult mental health through 2 programs, AgeWise and Pearls, to provide in-home services to older adults who are suffering from mental health conditions. That has taken place. To also expand evidence-based SUD services, which is what we're discussing today, and then early intervention crisis programs for children 0 to 5 and maternal mental health, and then also to support expansion of peer respite programs. So with SUD as the focus, the Commission staff set out to learn from various individuals about the work that they were doing to address needs around SUD. Staff conducted interviews. Michelle Nottingham and Vicki Kimmel, give them a shout out because they got in their cars and headed out to talk with local battalion chiefs. They visited UC Davis ER, their bridge program there. They went to a homeless encampment to learn about how those programs provide shelter and then referral to SCD services. And they spoke also to a representative of Sacramento Probation Department. This effort then was followed by the LA site visit, where staff and several commissioners went out with street medicine teams in September and saw firsthand the devastating impacts of drugs and alcohol. We also saw historic efforts by street medicine teams and case managers who are saving lives in Skid Row. We are also struck with how creative, unfortunately, how creative programs need to be to provide the medications to assist treatment, for addiction treatment. That's what I think this initiative is trying to resolve, making this easier. The next day at the Commission, September Commission meeting, we heard from a panel of experts on what is needed to provide the best treatment possible for people with SUD. They encouraged the Commission to do a few things. Sorry, I shouldn't be doing this, but I should let Cody do this. We are encouraged to do 3 things: scale and expand access and infrastructure across the state for medical treatment of opioid use disorder, provide whole person solutions, and integrate medical care, behavioral health, and SUD treatment options, and meet individuals where they are, and then to fund high-yield innovative programs. So Commission staff, along with Commissioner Danovich, then met with Governor's point person on SUD, Tyler Sadwith from the Department of Healthcare Services. We met with Deputy Director Stephanie Welch from HHS, county SUD leads, and the former director of the California Alcohol and Drug Programs. So after compiling all that we heard and in coordination with Commissioner Danovich, we're proposing to provide sole source contracts in 4 separate areas to enhance SUD treatment and build a team that will guide and inform the Commission's SUD efforts over the next several years. With 80% of the funding, or $16 million, we propose to launch a county best practice pilot. The pilot would involve 4 counties, including Los Angeles and 3 additional counties from separate state regions and serving diverse clients. The pilot will include medications or MAT, clinical cost-sharing program within the specialty SUD system. When I say MAT, I'm referring to medication-assisted treatment or medications for addiction treatment. Los Angeles County and 3 additional counties will join a cost-sharing program, which will help agencies provide the SUD services to hire clinicians that can prescribe medications. This has been seen as a significant barrier. This will address one of those key barriers to scaling MAT services and will establish a pathway to sustainability through the Medi-Cal drawdown. So this effort could support approximately 80 new MAT healthcare providers serving specialty SUD system clients. That's one component of the pilot. The second component of the pilot will expand integrated medical services in residential facilities. These facilities are considered many times non-medical, and as such, they have not been providing MAT services. However, there is a provision that allows them to do so, allows residential settings to provide these, what they call incidental medical services, to offer MAT as well as other medical services. The funding will support residential facilities serving Medi-Cal clients with obtaining this IMS approval to expand their capabilities to provide more integrated services for clients. So the funding amount is anticipated to support at least 45 residential SUD sites in obtaining IMS approval, which will allow them to offer the medications. Without that, they often have to go to different places, and it goes back to the availability versus access issue that we talked about. So the third component then would support expansion of LA County's innovative MAT consultation telephone line. This line allows the program to reach into additional communities that are sometimes hard to reach. The line is staffed with prescribers as well as substance use navigators who are peers, who have been through treatment and are in recovery themselves. They can help to conduct assessments through the telephone line and then connect clients to MAT prescriptions through participating pharmacies and smooth that process. One of the things we heard in LA was that it's sometimes a difficult process between being prescribed MAT and then receiving it through a pharmacy. So, and then the remaining 20% will be set aside for TA to the pilot counties, reporting out on specific outcomes, and then for a project manager to bring all of the various parts together to guide commission staff in this work and then to create the learning network. So I wanted to highlight that the outline and this slide, the outline in your packet provides actual dollar amounts on each of the areas related to the 20%. I would ask for some flexibility on that, as we don't know exactly what those numbers will be for TA and evaluation and for project management. So that flexibility is helpful so that we can adjust amounts if necessary to move some of those funds into the different buckets for that 20%. So we think this approach is a first best step, which allows the Commission to support existing work that's being done by the Department of Healthcare Services, but also provides the opportunity to pilot programs that bring health, mental health, and SUD services into SUD treatment settings. So we know that more holistic, integrated approaches are more effective and provide easier access to the services that people need. So our goal will be that the various systems will come together to make the experience more accessible and effective. So $20 million is, like I shared earlier, a small amount of money, but it can do great things. It's small compared to other efforts, but this proposal provides the Commission an opportunity to begin to build a team of consumers, providers, and experts who can guide efforts toward building a first-class system of care that provides life-saving treatment for SUD when and where people need it the most. If approved, Commissioner Danovich would continue to guide staff efforts to identify the county participants and additional contractors. We would then return to you on January 25th at the Commission meeting in January seek approval by the full commission on the selected counties and contractors. And then we would anticipate that we'd be able to finalize contracts by March of 2024. And so the proposed motion would be that the commission approves allocation of $20 million in Mental Health Wellness Act funds with 20% set aside for technical assistance, evaluation, and project management through sole source contracts to support evidence-based substance use disorder treatment and to address service gaps to reaching American Society for Addiction Medicine standards. And with that, we'll take any questions.
I have a question. Tom, can you explain just a little bit more? What are the set aside, I think you said, for the SUD providers? They would be able to provide MAT services within the licensed facilities?
Right. Yeah.
So how would they be screened? Because not all SUD providers are the same.
Yeah, that might be a better question for Commissioner Danovich, but they would have to meet standards, California state standards, in order to prescribe medicine in those facilities. I mean, that's one of the barriers, actually, is to help prescribers reach those levels of those standards, and then to bring them into the facilities where they aren't currently able to provide those services. So I don't know, Commissioner Danovich, if there's anything else you would add to that.
Well, does that answer your question? I could add a little bit more detail, but I want to make sure I understand your question.
Well, the question is, so we are speaking of funding that would be available to providers. Are we talking SUD providers, private licensed facilities, those individuals who right now cannot provide SUD services? They do other things within their programs to help individuals who are suffering from addiction. But would this commission be allocating dollars to the counties to allocate to those programs? Would those programs be getting those funds directly to provide those services? One, and then two, how do we screen them to make sure that there are safety mechanisms within those programs for these individuals? Unfortunately, sometimes there's exploitation that goes on with individuals who are in SUD programs. So my concern would be to really ensure that participants are getting the help that they need while they are actually residing in a program. What are the mechanisms or the safety considerations? How are those participants going to be selected? Or do you know at this point, who makes that decision?
Well, it's a great question, and it's a great question and set of concerns. This focuses a level above that, right? This focuses at the level of programs for whom there's a desire that the programs that are currently offering psychosocial services also offer medical services. Those medical services may include medication treatment for people who need it for opioid use disorder. They also may include other medical services that patients need that they're currently not getting in those programs, for psychiatric conditions, for other health problems. So the bigger change that we are aiming towards is to integrate medical care with the psychosocial care so we can get holistic care. There's a lot of facilitators for that right now, but for programs that historically have been predominantly psychosocial, it's a pretty big lift for them to become medical because it requires changes at many levels of the program and their cultural and their staffing. And so these funds go to programs to help them with the cost, the upfront investment that they need to make to change the programs to be able to facilitate greater integration of medical services and to bring on medical providers who then independently bill for their services. And that's why we think over time, this should be self-sustaining through funding mechanisms. So that's kind of where how the funds flow. Now, your other question about how do we ensure quality, and this doesn't control that. I mean, that's subject to the same risk and the same mechanisms in terms of licensure and standards of care that exist in this space. And absolutely, it's our it's safe and effective and appropriate and ethical care is vital. But this doesn't alter the existing mechanisms and licensure that preside over that.
I'll probably have more questions, but thank you. Thank you for that.
Commissioner Chambers, please.
Yeah, I think that Commissioner Danovich answered a lot of it, but my question is also the sole source contracts, specifically, would we be doing a competitive bid, or whenever I see sole source, I kind of get like,
Yeah.
Yeah,
I would say a few things. First of all, we're permitted by the Act to provide sole source contracts if that makes sense and is in the best interest of the people of the state. And that's determined by, whether we have an awareness of counties or organizations that have a rare expertise who are more ready than others to enter into this work. It also allows us to respond, a sole source contract allows us to respond much more quickly to what is a growing crisis and is currently taking lives. And so we feel like because of that, it would be in the best interest of the people of the state to move forward in that way. But yes, I understand the concern. We typically conduct the SB 82 contracts in a competitive procurement, but those have been more generalized programs where all counties might be ready to operate those programs. In this case, we need to bring on specialists who are experts in this area and have some readiness. We did this in some way with the Mental Health Student Services Act. When we launched that, we took $20 million from SB 82, and we decided to find the 4 counties in the state who are most ready to launch school collaborations between behavioral health and school districts. We were looking for the 4 counties who were the best at that, who were already doing it. And the reason we did that is because we wanted to learn from those 4 counties before we then were able to launch a more significant amount of money. And so we think the same thing could happen here through sole source contracting, that we can identify counties who are a little further down the road so that we can then learn from them and spread that learning around to other counties and do much of what we've done with MHSSA in this realm as well.
Yeah, I just want to make sure that money goes to the people that are doing the work, that are on the ground, that look like the community that they serve. And I know that people that prescribe, professionals that prescribe medicine are very short. There's a limited supply of folks with that specialty. So I could see where you would there's a smaller pot of people to pick from. But
Yeah.
just making sure, because, I'm a, BIPOC run organization, and I definitely wouldn't be competing for this, but I'm always thinking about the people that have been doing this work on the ground, and they have a hard time competing with bigger agencies that have resources, that have access to psychiatrists, that can do these models. Like they do focus on the psychosocial stuff. And I mean, I see that it's just one of the biggest barriers for all providers to even get a doctor or psychiatrist. We want them at the table, but they're really hard to find. So I'm excited about this. I hope it's somewhat competitive, and it really helps the folks on the ground.
Yeah, I think that's a box we're going to definitely have to check. Just in looking at some research, one article from Yale School of Medicine, that 90 to 92% of Black and Latinx communities who have a diagnosed SUD are not receiving treatment. And so there are significant disparities. And I think we're going to have to make sure we check that box for sure.
Thank you. Thank you, Tom and Commissioner Danovich, for your work on this presentation and the proposal. I'm going to agree with Commissioner Chambers around the issue of sole source contracts, just because I could see why with MHSSA, where between county and school districts, that kind of sole source is really great. I think part of what, and I heard you share like some of the learning and then the approval from the legislators for us as a commission to put out RFPs and then also be able to sole source it, versus just handing all the money to the counties, right? Because of the learning that sometimes it takes a long time to roll it out back to the community. And I mean, I understand because there's a lot of, government entities have to go through a process and you need capacity and all of that. And with SUD, I don't know how many other counties, but there are a majority of the services are provided by the community-based organization, if not 100%. Counties contract and depend on those expertise of those local nonprofit CBOs that are in the community doing the work. So I think this is really, a progressive idea and proposal. And I think the piece that you might, if you're trying to get it out to the community, it might be actually quicker going to the actual providers and putting it in a fair process of an RFP for them to, demonstrate how they can roll it out immediately and meet these goals. I think around the strategy, I would, as always, and Commissioner Danovich knows I do this quite often, is advocate for that, hiring peer support specialists in this piece, because I think when you're talking about Matt also, there's the opportunity to use this to build the relationship with folks that have been through it and can guide someone. I know the navigators are going to be through the LA County MAT line, but nothing beats having a full-time position where you can meet with the person that you're supporting and then connect with them outside of a phone call, which is also very important. So I wanted to elevate that piece because all of this for the SUD system, they do hire. I mean, they are almost all of them are peers, have lived experience. That's what their passion is to be in the. But I calling out having that partnership with a clinician that prescribes and a SUD peer is, I think, just would be amazing. So I just wanted to add that piece. All right, thank you.
Thank you, Commissioner Templin. Please, Commissioner Mitchell.
Dr. Danovich or Tom, did you say that it would be 45? Was there a specific number of 45 clinics?
Yeah, the estimate would,
providers.
that second part of that pilot would serve 45 residential facilities. The first part of it would bring on approximately 80 new prescribers. Those are individuals with a medical license who would be prescribing medicines.
Thank you. Did you have a question? So I don't know if I think it's a question. I don't see, and I know 20 million doesn't go very far, and I know we need to start somewhere. I don't see any prevention, and so I just want to make note of that. I'm really concerned. I also remember the panel that we had, and if you remember, we keep seeing accidental overdoses, especially in our young people, and we're losing many of them. So these conversations keep happening. I think we've been talking about specifically around fentanyl, accidental overdoses, and when we had that emergency room doctor on the panel, and we were talking about it, and she mentioned, when you say accidental overdoses, and then when you look at their background, there's a history of use. So accidental overdoses, and you have a history of use. So it's bigger than, it's not just the one and done, right? One pill can kill. It's not that. So we also are seeing addiction, maybe not identified as addiction. They're not getting services. So I really just want to say, can we continue to look at prevention? What are we doing about that?
So let me comment on that. It's a great point. And I would say first, yes, yes, we need to do more prevention. Yes, Commissioner Tamplin, we need to do more to add peers. All parts of the pipeline for the workforce, we need to bolster. I would say that what we're talking about is prevention. There are many points of prevention. What is this preventing? This is preventing people who have substance use disorder from winding up overdosing or winding up on the street because they didn't receive evidence-based treatment for their substance use disorder, because they went to a program that was limited only to providing one set of services and not another set of services. I took care of a patient last week who was pregnant, who had schizoaffective disorder, a psychotic disorder, would have periods of functioning really well and periods of having psychosis, and a severe opioid use disorder that needed treatment. Psychiatric programs wouldn't accept her because they couldn't deliver the medication treatment that was helping with the opioid use disorder. And substance use disorder programs couldn't take her because they couldn't manage the psychiatric condition. So, what is going to happen to that person? She's highly likely to slip through the cracks. And so what we're trying to do is have a substance use specialty system. That was kind of her, at the time, her primary issue, because her mental illness got stabilized, that could do both, as opposed to only deliver a social model, which she needs, a psychosocial model. We need a psychosocial model and a physical health model. Now, when a program does that, it elevates everybody, because the program involves counselors. Hopefully, it also involves peers, and everybody becomes more familiar with each other's language, and everybody becomes better at being able to deliver an integrated care experience for the patient. So I do think it's prevention. It's farther downstream, right? It's not kids in school, which we certainly need also. But what we aim to do with this, since 20 million is a lot, but it's a little, it's a drop in the bucket for what we need in this space. We wanted to focus to identify counties that were prepared, that already wanted to do this, but needed a little bit of support, creating incentives to make this happen, because everybody kind of knows theoretically this stuff needs to happen. It sounds obvious when you talk about a patient. And yet, at most counties, there's just so many barriers, and the change management is so difficult that we don't have people clambering, to try to do this at all odds. So that's why we ended up focusing in on which counties were ready to really participate, kind of wanted to do this but needed some help, and then how could we help get things over the hump to make it happen and execute it in a short period of time.
Thank you, Commissioner Danovich. Absolutely agree. I see where this is prevention, and I still, and that it's that continuum of prevention, right? So I absolutely see what you're saying, and I know we have to start somewhere. And I do think about those kids that I'm sitting in the child review board. So thank you for that. I believe there's another question, so please, Commissioner Bench.
I agree with everything that you just said, and I definitely see it in working in the field and going in and doing the evaluations in the prisons. I have a more logistical question. Why do we give the contracts to the big counties who then contract them out to the smaller programs?
Yeah, I can answer that. I think through our work we've recognized, and we recognize that LA County is the epicenter of this problem. And when you're a county that's the epicenter of a problem, you develop programs and services that you have to develop in order to meet the needs of the people of your community. I think LA County has doing that and is doing that, and I think this. They have become a leader in this way, and can provide technical assistance and help to other counties who are also dealing with this significant challenge. So That's why, really, because they have more to work with, more to deal with in terms of the services.
Another question.
Did he?
And we also have other counties that are included in this, do we not?
Yeah, that's right. And up to 3 other counties from 3 other regions of the state: Bay Area, Valley or Central Valley region, and Superior.
Commissioner Mitchell, then Commissioner Tamplin, please.
Thank you, Dr. Danovich, because I do see the prevention strategy in that. I sincerely do. One of the things that we did observe in Los Angeles that was brought up was the disproportionality regarding what medications are put in which communities. So I am interested to know which medications, or do we know at this point what would be buprenorphine? Where would that be versus another medication in, let's just say, on Skid Row or Watts? I'm just curious because that was a big part of the discussion of who gets what in terms of how these medications work.
Sure. Well, for those of you that just don't have that background, there's really well-documented disparities first between access to medication treatments between people of different races and socioeconomic status. So people that are, Caucasian versus Black are much more likely to be on treatment, period. And then also the types of treatment historically have been the subject of racist policy, frankly, and you're much more likely to see methadone in some zip codes than you are in others. And you're much more likely to have buprenorphine among people that have commercial health plans and that have personal physicians that are prescribing it to them. So that's the legacy we walk in with. There are efforts to unwind some of the policies that have contributed to that. So one example of that is the waiver that limited physician prescribing of buprenorphine was just eliminated to make it more possible for physicians that don't have the specialty training to receive it. And the impact of this would be just more programs having the capacity to start patients on the treatment they need, whatever their background is, right? Agnostic to their background. So this is not going to like methadone programs per se or opioid treatment. This is programs that are taking care of patients. And then it's adding medical providers who then, in accordance with their license, can prescribe whatever is appropriate. It doesn't dictate that they're going to prescribe buprenorphine or that they're going to prescribe methadone or that they're going to prescribe a treatment for alcohol use. Because that's also, by the way, alcohol kills more people each year than opioids. And appropriate treatment for alcohol is a part of this also. This is just focusing on making sure that the programs that are providing care for substance use disorder have access to appropriate medical service in addition to psychosocial service. And I think the more that exists, the more I think we're going to be reducing disparities. The disparities have to do with the fact that there's such differential access to services at all.
Agreed. Thank you.
I'm curious if you're open to, again, doing the RFP routes, again, and opening it to the actual providers that you're speaking to that have been doing the services. If it's county run, then the county has the ability and, like you said, ready to submit a proposal about how they'll do it. But if it's also, you might really get an incredible, there's many incredible CBOs that probably would love to apply and show that they can do this and maybe roll it out quicker and get to more people and have less overhead. And so just that piece, if that can be part of the equation, I think that would be really great.
If I could add something to that, some of that is obscure to me, what Commissioner Tamplin just said. However, what I understand practically, if that's possible, I do think it does get to a lot of the things that Commissioner Danovich talked about in terms of integrated care and ultimately expanding capacity. And maybe the process is a bit more rigorous and taxing for staff because you're dealing with a number of entities. There's more CBOs than there are counties. However, ultimately, I think the outcome would, and what you'd be testing could be tremendous. And I do think that you will get at least a value for your dollar that would be equivalent and I dare say maybe superior to that which you might get if it goes to the county. Now, and I'm owning my CBO bias. I have a little bit of CBO bias there. I own that. But if you walk that out, and given the amount of money that you have, I think it'd be a tremendous experiment. And so I'm going to endorse what Commissioner Tamplin just said.
I promise. Just to close it out, I had a conversation with LA County's SAPC department, the ones that do the substance use, and they had noted that they actually, I mean, I could be wrong, and if LA County's on here, that they actually subcontract out with a number of providers, and that, because they had approached me about my peer curriculum and wanting to get more peers integrated in substance use, so I know that they're taking that as a big initiative. So like, to just that point, I mean, if the process is easier to go through a county, but like, we know, like, I have knowledge that, it's mostly like the CBOs and the folks that are doing it. But if they can also bring medical providers faster to the county, and, I think that's the other thing, like, we have an issue, like I said, with being able to get medical doctors, prescribers. I mean, that's our biggest issue. So that kind of partnership, if that makes it robust, then, I think it's a good idea, but definitely know that in the county that I am in, I believe it's all subcontracted out.
Thank you. Toby, are you on?
Yes.
Can you respond to what you're hearing, to the conversation? Because it's, as we're talking about it, it seems that what we're saying is we could have these community-based organizations, and you're hearing the conversation. I'd just like to hear some of your thoughts.
Yeah, I want to clarify, and so in terms of this, I think there's a couple of issues here. There's the sole source versus competitive, right? The challenge we have with a competitive procurement is this focus on sort of picking a handful of opportunities to learn from. LA, pardon me, because it is, such a large, the challenge is so large there, and there's a sort of ready willingness of the department down there to engage on this strategy, particularly around some technical assistance to the community providers who actually would benefit from the dollars to add this medication-assisted treatment to the array of drug treatment services they provide. But we recognize that it's also valuable to learn about how this investment can impact the access and quality of care in other parts of the state, particularly the Central Valley, Superior, California. And so the proposal was, up to 3 additional counties. And I think we might have got a little confused here, at least in my mind, that did not necessarily mean that it would be the county behavioral health department who would be the contractor. The contractor could be a community-based organization, something that we would want to sit down and negotiate with based on the capacity of those partners, their willingness, their capacity to engage, right? There's a couple of things that are happening here. We're trying to provide incentive dollars to fill a gap in the quality of care that the state of California has already established standards for. As Commissioner Danovich says, the standards are in place, the providers are in place, but there's a gap because we haven't been able to help those providers get over the change in the standards in a way that will allow them to benefit from the newly available revenues under billing changes that are being implemented, financing changes that are being implemented. So this is sort of a short-term patch to learn, to help the provider community learn. And it sounds like the commissioner's comments are the tension between the dollars going to a county behavioral health department, which would then contract with CBOs. And I think what Tom is suggesting based on the conversations with Commissioner Danovich is we really want to sit down with the community and figure that out and find the right kinds of partners, because it's not going to be a lot. It's, yes, $20 million is a lot of money, but in the scale of the problem, it is nowhere close to what is needed. And so we want to be really strategic, and we're happy to figure that out and come back to you with the details at a later date if that's what you want. We're happy to sort of continue to move forward. And so, but we wanted to put the proposal on your agenda, have this conversation, get some guidance from you, and see if we're headed in the right direction. Personally, I think, based on the panel we heard, based on conversations with the provider community, certainly Commissioner Danovich's leadership in this space for many, many years, I just wish we had more money. Unfortunately, we don't. And so my recommendation would be is if you're hesitant on the sole source or anything along those lines, give us direction to move forward with this work, but to withhold actually entering into the contracts until we give it to you, as we would hope as soon as January. And so if that's, again, my job is to help you find a way to get to something that you're comfortable with. I'd want to affirm with Commissioner Danovich that that's acceptable, and with Tom that that's practical.
Yeah, I think that, that's part of the plan would be to hopefully move forward with the approval and then come back in January, at the January meeting, to share with you those that we've identified for funding.
Well, Tom, I want to clarify. It's one thing to say they approve it and we sign contracts and we notify them in January.
Yeah, approve the plan here, but not necessarily the contractors.
The expenditure.
Not the individual contractors, right? Just
Right.
moving.
Those are your two options. That's right.
Certainly would be comfortable with that and not moving forward with the contracting process, because again, a lot of questions have come up about that.
Yeah, absolutely.
Thank you.
Thank you, Commissioner Rolette.
Can we then change the wording of the actual motion to indicate that we're not just going with the sole source contracts?
So the motion would be so I actually don't know that you need a motion and a full vote at this time, because you're not spending dollars. If that's the case, it would be just, the direction to continue to flush out the proposal and to bring the actual spending proposal back to the commission, at the soonest available date, which we would work towards January for. Now, and again, we're going to caution you that we'll run out of time on sole source contracting. So if that's a deal breaker, it's really important we know that now.
I guess I know you said it, but what is that, like, laymanly? Does that mean that we're going to go through the counties and the counties are going to sole source? Or what is that?
No. That would mean the commission has sole source authority to enter into contracts with county behavioral health departments or with direct providers.
Okay.
Or and so there's a component here around technical assistance, some project management. We do not have the staff capacity nor the expertise to, really project manage this. And so, in general terms, the commission has the discretion to do either competitive procurements, RFP kind of procurements. They take a lot of time. They're really important when we have a very clear understanding of what we want. And there's lots of folks who can provide that. They're very difficult when we're trying to achieve something that's a little that's specialized, and there are fewer providers who can do that. In this instance, we don't have a lot of money. And so the recommendation is to leave on the table the sole source contracting, which allows us to negotiate a strategy with individual partners with, and what staff is saying based on this consultation is LA is, a key partner because of their willingness, their readiness, and the scale of need. But we recognize that LA is not the only community that is struggling with this need, and we would want to make sure that we learn lessons around delivering MAT in rural communities, let's say, that have providers. But what about rural communities that don't have local providers? How might we use some of these dollars to see if we can design strategies to do that? All of this designed to support and inform the much broader initiative that DHCS and the Health and Human Services Agency is rolling out in terms of elevating SUD services statewide. This is a gap between where we are today in terms of policy, access to care, quality of care, financing of care, and what's anticipated on the horizon over the next 2 or 3 years, that we can use these dollars to learn how to do this and support the ability of the SUD provider community to learn and develop that strategy that can be sustained as new financing tools take effect. But Commissioner, the whole idea is we need to make sure we have the right partners who are ready to go, that they're supported in a way that'd be successful, and that this is not duplicative and it is targeted to the highest level of need. That's very hard to do with a small amount of money in a competitive procurement in a short period of time.
And if I may, I just want, if we do vote on a motion, I want to make one comment just in support of the original motion that was on the table to do a sole source, contract. I hear the concerns and the comments that have been raised by my fellow commissioners, and I share them. I think that having competitive processes is always better when you can. I think that we needed to work with a county that has the ability to do the technical assistance, that gets what this project is and can demonstrate that it's possible. And in the spirit of effectiveness and focus and acceleration, we identified a county, LA and SAPC, that was very engaged with this. And our hope was that in demonstrating it, we could then generate momentum to bring in more funds and to be able to do this more broadly. So while I in theory I agree with all the comments that if we did that, perhaps there are other entities that could do this. I do worry that by introducing slowness and more steps, we may not get to where we need to get, and that there's a cost to the delay. So I would argue for giving the approval. I think a lot of thought went into this by staff to develop and prepare the proposal that you have at hand. The feedback that's been given is going to be integrated in the next steps, but I would hope we don't encumber it with more process steps and all the delays that are involved with those. But respect whatever my commissioners however they choose to vote.
Can we at the least encourage the counties to not contract it out and to do the work themselves?
They have, so the counties rely on programs to deliver many of these services. That's how they're structured. So we can encourage, but I don't think we can dictate that because of how the system is structured.
Chair, one quick question. So this is a really late question and probably so unfair, but I'm sorry I have to ask it. Was LA County the only county ready? I mean, we just came from Siskiyou. I mean, we just came from Lassen County. I assure you, they would say, hey, we have the same need up there, even though it's a smaller county. But I'm just wondering, was Alameda County not? I mean, I'm just curious. Was LA County the only county that was ready to go?
Well, what we propose is that we would start there. Like I said, I think this is our first, best step that we can take. And the thought was to start there and then identify counties in each of those regions. Siskiyou in the Superior region, I'm not sure. We haven't decided that. That's not something that we've worked through. But we do know that it makes sense to fund programs in the other regions besides Los Angeles, so that we can start to see spread of these ideas in this program. No, they have not been identified, and we've not worked with specific counties in those regions.
Chair, I just need, Toby introduced the concept of something that I didn't appreciate. The opportunity lost if we do not approve sole sourcing today. And again, Toby, I'm not fully, I thought I understood it, but then after Commissioner Danovich just explained it again, said what he said, I'm not sure. If you could just tell me what are the, I'll just say, describe it as opportunity cost if we don't approve this today in terms of sole sourcing and wait it until January.
Well, thank you. That's a very large question. I think there's a couple of ways to answer that, right? Well, I should say between now and January, the difference is it's not as great, right? I think the question for us is the confidence that we're headed in the right direction, and do we do a tremendous amount of work and then sort of have to pivot come January, right? We don't come to you often for sole source contracts of this scale. Typically, they're a couple $100,000 or less, $5,000, right? We don't even the $5,000 one, the chair reviews, but we don't even put them on your calendar. It's very unusual for us to ask for sole source contract for these dollars. The issues are a couple of things. One is the time that the commission has to encumber these dollars. And Norma or Tom can correct me, but my understanding is that these dollars will sunset if they're not encumbered by the end of June.
June 30th, 2024.
Yeah. So the opportunity cost, Commissioner, it is very hard for us to do a competitive procurement in 7 months, particularly a competitive. But the real reason for the sole source isn't that we can't get it done in 7 months. We could. Our team is so good. They're also really tired because they've been doing a tremendous amount of procurements around CYBHI. I think we've got $200 million of sole source procurements active, actually probably more than that right now. But the real reason is this is a specialized procurement. This isn't about sort of a generic response to a generic challenge that is consistent from Imperial to Del Norte, right? What's happening in terms of access to SUD services is different in LA than it is in Del Norte, based on how their SUD agencies are organized. In some counties, it is the behavioral health director. In some counties, it's not the behavioral health director, or it's an agency structure. As you know, Nevada and YOLO were very different from Sacramento or LA, right? Then there's the mix of community providers and their willingness and readiness to participate. Then there's the availability of the prescribers in those communities, right? For us to do a competitive procurement to reflect that array of complexities in a short time frame, while we could pull it off, we don't think it would be fair and reasonable for the community to sort of drop everything in November or December to put a proposal together for what in essence is not a lot of money relative to the need. Instead, what we're asking of you is to allow us to sit down with some key partners and figure out who's ready to go, what seems reasonable, so that goodness of fit that we talked about in the strategic plan, where's the impact going to be greatest? Where's our capacity really aligned? Where's the capacity of the local providers aligned? So, Commissioner Mitchell, we've not actually surveyed all of the counties. We have had conversations with the provider community. We have had conversations with some counties, but we needed to put this in front of you and have this conversation before we invested a significant level of additional staff time to try to figure this out, because we wanted to make sure we were headed in the right direction. I don't hear any concerns other than the chair's comments about emphasizing prevention versus this treatment strategy. So it's incredibly consistent with the panel last month in San Francisco, very consistent with the walking tour, street medicine tour down in Skid Row. Part of the challenge is when people are saying, I'm ready for treatment, it may not be there. And so, I think we're trying to just narrow down the number of unknowns and get clarity from you of what you're comfortable with for next steps. I think what Commissioner Danovich is saying is, to be efficient and to be responsive, the authority to do sole source and to figure it out as we go. But if that's uncomfortable, then it would be get us to the next step, which is to pick the county, pick the provider, right? The challenge we have is if we do that now and you say, actually, no, I want this for prevention, we have just exhausted ourselves and gone in a direction that wasn't appropriate. Does that help, Commissioner?
But the first 2/3 of your presentation were my question precisely. What I understand now is that the opportunity cost is associated with the June deadline. And what I also understand is that as Commissioner Danovich said, a competitive procurement is always more ideal. I also want to speak to my sense of my responsibility here as a commissioner, and that is to ensure the public and to the staff that our process appears as, for lack of a better word, as rigorous as possible. And so all of those factors I'm thinking about, and so I may want to reflect and pause and think about this, but be prepared to say in January, get me more information that speaks to my concerns, and I'll see what the other commissioners have to say about that. The last point that you made, I'm 100% on board with. I trust that your process was rigorous. I trust certainly LA is the epicenter. You don't have to convince me. I'm convinced. I'm convinced.
Commissioner Brown, please.
I know we're late, and I know that we're going off into some rabbit holes here, but I do want to just bring up the point that the language is pretty nebulous in terms of community county organizations, and my specific question is, and I haven't been able to find it in 184 one way or the other, but in terms of, are jail-based treatment programs eligible under the change in the MHWA, and would they be eligible because frankly that's where you have a big number of people who are ready to go in terms of, I want treatment, I want to get something going. You have a captive audience and you have a high level of success that sometimes doesn't exist in community-based treatment programs, where they're still out with a lot of temptation and a lot of so-called friends that are diverting them off into on the wrong paths. So can you address the eligibility, if you will, of jail-based MAT programs?
Yeah, I don't know specifically. I do know that 184 broadened, the type, a number of facilities, organizations where these funds can now be available. So to this point, we've provided funds in the hospitals, and then to mobile crisis teams. But yeah, it's a wide list where we can provide funds. Toby, I don't know if you specifically know about 184, but I believe the answer would be yes to your question, that these funds would be available for jail-based services, but I would have to confirm it.
Yeah, I think I don't have the answer to that part, but I could say that for the initiative that we explored, right, this is for an initiative that there are initiatives to try to improve access to medication treatment in jails, which I think is what you're speaking to, Commissioner Brown. The programs that that contract with the counties around delivery of specialty substance use disorder services frequently support people that are on parole and probation and that are at high risk of being reincarcerated related to relapse, of their substance use. So I do think that that those people are served by better integration of these medical services in the specialty treatment programs. But I think you're speaking about specifically jail-based.
Well, and recognizing that the jail-based treatment oftentimes precedes the community-based treatment. In other words, for that person that's on parole or probation that can start on MAT while they are incarcerated, particularly if they're on long-term injectables. Again, it is a potential, I think, to enhance the success of that. But the reality is, many jails, my own included, have waiting lists of inmates that want treatment, and we can't provide it because we don't have a budget for the pharmaceuticals. We don't have a budget for the additional medical staff that'd be required to hand out the medications and so forth. And so there are also, at the same time, say two other things here. There are a variety of other funding sources that are out there that people are competing for, one of which is the use of the settlement monies from, in which it's clear that MAT in jails is eligible for and certainly have applied for. But I think that the notion that we need to, all recognize, and I think we do, that $20 million is not going to solve our problem anyway we slice it. And we also recognize that it's a unique situation in Los Angeles County because of the size and the magnitude of the problem and the scope of the problem that they have to deal with. So I'm fine with both of those notions. I guess it's just a little ambiguous as to how will the other counties be selected and what type of programming is available to counties that want to do it, particularly if it's got some connection with their criminal justice agencies.
Yeah, our hope was to, present this to you and have you consider that we would allocate it in this way, and then in January come back with specifically how those counties were selected, what the criteria was, and I think the discussion here today has been helpful in terms of determining that criteria. Are they going to be able to reach the people they need to reach with the services? So.
Thank you, Tom. So, Toby, Jeff, I'm going to ask you to what Commissioner Brown was saying. I think that we are halfway there. I think we want to come back in January to really flush it out. I think that we are in agreement with Commissioner Danovich, his expertise, what he's proposing. I don't think we disagree with that. I think we do have concerns about how those other counties would be identified. I, like you, Commissioner Brown, I do believe we have, LA is the epicenter and they have capacity. So understanding that, but we have questions about the other counties, what that would look like. So I think we need more clarification around process for that. So Jeff, having said that, Toby, having said that, could you get us to where we need to get to move forward on this?
Well, Madam Chair, if I heard Commissioner Danovich, he was making an impassioned plea for the original proposal. And so, yes, there are some concerns. The question is, will the original proposal that the staff put together in consultation with our addiction medicine specialist, is there support? If there's not, we can certainly modify that and come back to you in January. We can do more homework and come back to you in January. But it's, what I've heard is this very clear recognition, and this came about in the strategic planning conversation, is there is so much unmet need out there that it's really difficult to allocate $20 million, as much money as that is. So I would ask.
I think our biggest threat is not our biggest threat is not getting things done. And I agree wholeheartedly with Commissioner Brown that the jail population needs services. Absolutely. I could identify a whole series of other populations that need services. We chose one place where we thought we could be effective and responsive and quick. And there are many, many good reasons to start in many other places. But this is a situation of let's not let the perfect be the enemy of the good enough. Let's do something as a demonstration project and then use that momentum to scale it to more and more other areas. So I would hope that I would make a motion to, vote on the motion that was there. And maybe we won't all agree with it. I think that's okay too. And maybe it'll get voted down. But I think it would be helpful to just make a decisive decision on it, it would help me. It would help commission staff. We've been thinking a lot about this. And it's okay if it gets voted down. We'll deal with that. But I'd prefer that than just a deferral to January.
Thank you, Commissioner Danovich. I'm going to second that motion, and then I'm going to have Commissioner Chambers, please. Make
Oh, no,
sense.
I just wanted to say that I second that motion, and I think we should put it up for a vote.
Thank you. So we are at a motion, a second, and a third. And then we are going to put it up. And- No. Yes. No. Any other questions or comments from commissioners at this time? No. All right, we are going to go to public comment. So, Mariani, if we could.
We currently have we have 2 comments, one in the room. Actually, we have a few coming in online, but we have one in the room. Stacy? Oh, she had to leave. Okay. Just kidding. She had to leave. So we'll move to online comments. Up first, we have Richard. Your line is open.
Anyway,
I had one now. Can you hear me?
We
Hello?
can- Go ahead, please.
Yes, I would suggest that if the commission would do their best to their ability to hire a appeal worker, I firmly support Commissioner Chambers to have a appeal worker as part of that SUD team. I currently work for an organization where we have one individual that all he does is work with individuals with both dual diagnosis mental health and substance abuse within the agency that I work for. And he connects them with programs and services and AA and A groups and all that. So if you would please make sure that not only that peer worker be part of the workforce, but also livable wages as well, because what you don't want is to have a program where you have a high turnover rate. There's no good continuity of care if there's a high turnover rate. So take that into consideration. Thank you.
Thank you, Richard.
Next, we have our last public comment. Laurel, your line is open.
Hello, this is Laurel Ben Hamida of Muslim American Society Social Services Foundation and REMCO. This has been a very interesting discussion. You are really between a rock and a hard place. Traditionally, this money would have just gone out fast, and it would have mostly served the people who already have some access, and that is largely white people. But now there are voices in the room and at the table that are saying, take a little more time. Be sure that your evidence-based practices are based on those populations and save some of those lives. So you can go fast and save the lives that would have been saved in the past, ignoring people of color and refugees, immigrants, and non-English language speakers, or you can take a little more time and you can reach out to those who have not been served. Either way, people are going to die because we're really in a really bad situation. Can you imagine? I've gotten Narcan handed to me twice in the last 18 months once at the Sacramento County Opioid Coalition meeting, which were mainly educators, social workers, the DEA, the FBI, and the sheriffs, and also at the peer conference. It's an amazing change that something like Narcan would be handed out for free like that. And that reflects the difficult position we're in. But as a friend of mine said well, that's because, white people are dying now. I don't like to put it in those terms every time, but I really did think she had a point historically. And you guys are in a really difficult position. And I really respect the conversation. And whatever you do, think about your intentions and think about your role as doing demonstration projects that do meet those communities that have not been served before. As our late Janet King once said, a lot of the evidence-based practices make our people sicker. And Native American Healthcare Center started on International Boulevard. There were 6 or 7 what were called Indian bars. After her center was in place for a while doing culturally competent services, those bars closed. There wasn't.
Thank you, Laura. Time is up. Please wrap up your comment.
Thank you, and appreciate the discussion.
Thank you.
That was our last public comment.
Thank you, Mariani. So we are going to Jeff. All right. Thank you so much. Thank you, everyone, for public comment. So we have a motion and we have a second. Jeff, I'm going to ask you then to take roll.
Commissioner Bontrager.
Madam Chair, before we vote, I've got one more question. Just I'd like a little clarification before we vote. And this would be for Toby, I think, or Tom. But the staff report indicates pilot project in Los Angeles and up to 3 additional counties, with the 3 regions mentioned. So I guess where I'm confused is here, are we proposing, what determines whether it's all goes to Los Angeles or there are 1 other, 2 other, or 3 other counties? How is that decision going to be made between now and January?
I think that's something that we could, Toby, if you want to speak. I was going to say, I think it's something we could amend, and we could say that, specifically we would do LA and 3. But Toby, share.
So, thank you, Sheriff Brown. The consideration there is, really based on that framework that we're trying to articulate in the strategic planning piece, identifying the key partners. We don't think we can do more than 3. There just isn't enough money. There's not enough money to do more than 3. We think it's important to have, a rural experience and recognize that, as I mentioned earlier, what's happening in the Central Valley and in Superior, California. But it's really a determination of how far we can make these dollars go. I don't think doing, 1 county, we don't learn as much. 2 is better, 3 is better than that. There may not be enough money to get to 4, which is why we wrote up to 3 additional counties. For me, the sweet spot would be figure it out with LA and then find 2 additional community partners, 2 county partners. Again, it may not be the county behavioral health department. It may be community providers within 2 other counties. But it's really a practical question of who's interested, who has the capacity, and do we have enough money?
I get that and I hear that, but I think that the problem is it is so nebulous that we don't, in some respects, we don't really know what we're voting on here for that. And so I would suggest maybe a friendly amendment to this that would perhaps, instead of using the regional approach, and especially if it's a may or may not make it kind of a situation, could we not presume that LA should get the funding because they are indeed the largest county with the largest problem, but that perhaps 2 other counties, a medium-sized county and a small county, perhaps should get funded, rather than maybe we go throughout the state, maybe we don't, and then the county sizes are determined on how much money is going to be, requested or drawn down and so forth. And I think if we could approach it as a small, medium, large pilot program that you know, is going to address, and as much as I'd like to see these funds go to the jail, you know, I realize that there's just not enough money to do that for everybody. But if there is, you know, a small, medium, large pilot project that would address this lack of medical expertise that some of the current providers, and I'm sure it's that way in all counties, don't have, then I think it might have a little less heartburn for everybody that's looking at this thing. And I don't know if quickly we would want to determine how much it would be, but if there's 16 million, you know, my thought would be maybe you look at, obviously the lion's share probably goes to LA, but then, you know, divide the others up in such a way that it makes sense for, you know, maybe $1 million for a small county and 3 million, 5 million, whatever for
862, or, yeah.
for a medium county. But I think if we don't do something like that, there's a danger of it, A, not passing, and B, it's kind of just, it's just too vague at this point for me.
In past efforts, we've based it on population and other data that tells us, you know, what is the cost going to be in a small county versus a large county.
Well, the state has existing criteria for small, medium, large.
Yeah,
counties.
right. 250,000.
If some of the concern is the vagueness of it saying kind of up to 3, which could mean, you know, only 1, perhaps if we were to add up to 3, but at least 2, you know, LA and up to 3 and at least 2 requires 2 other counties, so that it can't be less than that. I think that I worry just about the small, medium. That makes really good sense. I think we're gonna have to see who is able and willing and ready to just participate, you know, on it.
I think
So-
you'll have plenty that would be responding at a moment's notice. I think there's enough people engaged in MAT right now, both in and out of custody, that there would be plenty of people that would want to expand existing programs. And
So but the language you're suggesting for clarifying the county participants is what?
I'd like to keep it, I mean, out of respect for you, I'd like to keep it to the original idea of trying to address this lack of clinicians that can prescribe medications. And, you know, if that's the need, then address that. But, you know, I suspect that there's others like where it's going to be an issue for the cost of the actual pharmaceuticals as well. You know, so I mean, I don't know that you want to just limit it to a staff situation.
Jeff,
So-
I'm sorry.
Maybe I can provide just a little clarification in terms of process. You've been presented with an outline proposal. I would treat that as a guideline, as what staff intends to do, pursuant, of course, to your direction, which can be reflected here, or it could be reflected down the road. Legally, what the motion calls for is an allocation by the commission for $20 million. And so in it contains, the reference to a sole source contract. But beyond that, there's nothing else in the motion. And as I understand it from Toby and Tom, is that if you give this authorization for them to move forward, then work is going to continue to be done by Tom, other staff here, as well as Commissioner Danovich, to then identify who, including the counties, CBOs, and everyone else, the technical assistance providers, everyone else involved, is going to become identified. And then Tom will come back in January, seek your approval for the specific contracts and the amounts. So I say that just in hopes that we don't get too mired down in the wording of the outline, because that's not I mean, it's important, but it's not part of the legal motion here today. So I guess I'm trying to direct the commissioners to look at that motion and see if that's something that they can live with, or if that's something that they think they need to change, and have that direction specifically within the vote.
And I guess I would say, I've been taking lots of notes and hearing comments, and everything that I've heard, I'll ensure that staff work to include those as we search and identify those counties. From the two, at least two, more than three, no more than three. Also, to consider that we have as a goal small, medium, large. And so I think that can all be incorporated into our thinking as we then present you a plan in January. Hopefully we've identified exactly what I've heard here today, and present you with a plan that makes sense.
And the proposed motion is somewhat different than it's an overarching summary of the staff report, and doesn't get into the details about the how many counties or what have you, and it just does. And I can see how you've worded this now. So it's the 20 million authorization is to get us to allow you to move forward and work toward identifying the sources or the places that you will place these funds. And then bring that back to us in January for approval.
Well, I think the motion, I think that just that what we're asking for is to be able to have the allocation now and not to have to come back in January for reallocation. And I think that the question is, how can we incorporate Commissioner Brown's friendly amendment to ensure that we get, a reasonable distribution of different counties besides LA, which is a clear direction, which is in keeping with what we want to do. And we just want to make sure that that's memorialized somehow. Right, Commissioner Brown, do I understand your guidance there correctly?
Well, certainly that was my thought, is that if it had a little bit more clarity, there might be some more support for it. So. And I'm just trying to figure in terms of the.
So could we have Jeff suggest an amendment so that Commissioner Danovich could then accept that so that we could vote on?
Go ahead, Jeff. Question was about, would you suggest an amendment? I'm not sure. We saw this and I presented this hopefully as a two-step process, really. This step was to allocate the funds, get authorization to pursue sole source contracts for these different areas of funding. The reason for that is then we know as staff, what direction we can take, because moving down that path is very different than moving down the path of creating a request for application, which is going to be time-consuming, and it's going to run us up pretty close to the June 30th deadline. That's a risk, and so knowing today really helps a lot, because then we know that, okay, we're going in this direction. And the work then that we have to do is to incorporate your comments and make sure that what we present in January reflects everything that you've shared today. And hopefully we will get that right and be able to explain how we selected the counties and the contractors, and then in January to make that decision.
Tom, I don't want to bring this back in January. I think that you just stated you've heard all of our concerns.
Mm-hmm.
So knowing that you've heard all of our concerns, knowing what we want, knowing that we can vote on this if we amend this proposed motion to incorporate that we're going to be thoughtful about those additional counties, then we just need to change this.
But the way it's presented, it is coming back. It's supposed to come back on the 25th of January.
Either way, it sounds like.
That was our plan. But however the commission wants to move forward,
Okay,
with
I'm
it.
sorry, then
Yeah.
I misspoke there.
Yeah, our
But we
plan was
need
to-
to, in
yeah.
order to get this, if we can make an amendment to this proposed, so we can move forward on that, then we can do that in adding the language that Commissioner Brown just shared. So if we can do that, so we can vote on it. But then we already have a first and a second, so Jeff, I do need your guidance on that. Do we first and second and then stop? And then do the amendment, yes.
So, yeah, so we have to handle amendments first. And if they're friendly, then the person that moved and seconded can just accept the changes and we can move forward. Or we have to vote and do a two-step process, which is going to take even more time. So if, I'm certainly happy to try to draft a friendly amendment or a full amendment based on this most recent conversation.
Well, let me ask a question, and that is that does the amendment cause problems that I'm not seeing here as well? In other words, if the thought process was to go with this, the way you originally proposed to do this, with the regional division of the counties rather than the size of the counties, is an amendment to do it in such a way, is that going to hamstring you or the staff, Toby? I guess that's my question to you.
So, thank you, Chair. And we don't know that because, you know, it may be, as you say, it may be very easy to find a small and a medium-sized county that is ready to jump in. We want to recognize that there are massive reforms being implemented at, in the mental health system through CalAIM and our local partners are swamped. And so, I would love to say with confidence that we will find a small and a medium. That's the only consideration. My suggestion on a friendly amendment on the motion is to, authorize the use of the $20 million to find that it's in the public's interest to do this through a sole source, and to work with LA County and 2 additional counties, no less than 2 additional counties, ideally 1 small and 1 medium, to develop a program to improve access to medication-assisted treatment where necessary, under the direction of Commissioner Danovich, and to report back to you as soon as possible on the proposal. I think that, the tension is over whether or not it's a 2-step process for us to do the work and then seek approval of individual contracts, and I would defer to council, versus to have the authorization to move forward and sign these contracts and just to report out how that worked out. Whatever the commission feels is most comfortable. Certainly, as Commissioner Danovich pointed out, no matter what we do, we're not going to solve every challenge, make everybody happy. It isn't that we want to move with lightning speed. Even under these rules, we won't be able to move with lightning speed. It's really this recognition that in the grand scheme of things, this is a pretty small contract. And relative to our portfolio, certainly to the state's much larger portfolio, and then the need that is out there.
All right. With that understanding, I am prepared to move forward with an amendment as basically as described by Toby just now. That it would be the only adjustment to this was that there be 2 other counties that would be identified, 1 a small and 1 a medium under the state's definition, and that we would then come back and, as you recommend, on the 25th of January, approve the entire process.
Mm-hmm. Yeah, I'd recommend that it could say that the pilot program will include at least 2.
At least 3.
At least, okay.
LA plus 2.
Yeah, okay. At least 2 additional, yeah, okay.
And would you all explain to us how you selected those 2 counties?
Yes.
Okay.
Jeff's writing it up.
Pregnant pause here, but is that,
Sorry,
the
yes, that's
motion?
my
I
head.
make the motion, so we can
And
vote
if
it
I-
up or down.
Excellent. I think I understand your motion. It's basically the motion that was presented, that the commission approves allocation of 20 million in Mental Health Act wellness funds, with 20% set aside for technical assistance, evaluation and project management through sole source contracts to support evidence-based substance use disorder treatment and to address service gaps to reaching the American Society of Addiction Medicine standards, okay, with the commission contracting with LA County plus 2 additional counties
Yeah.
for this project. Does that capture it? Oh, we don't. My apologies if I took that from the outline and the conversation. So you just want to say
counties.
3 counties.
I was under the impression that LA had already been identified. It does say pilot project in Los Angeles and up to 3 additional is what the current language is. So LA has been identified as what, under my proposal would be the large, medium, small county plan. LA has already been identified for that. And I think it's probably very appropriate that they should be. They've got the biggest problem of anybody. I understand that. But I think that, there needs to be just an understanding about that, because I just think that the way the staff report, up to 3, and I just think it's a little too vague. I just think it should be done. There's going to be a perception of fairness that is going to be important, I think, in terms of looking at it. It's a limited amount of money, but how do we divide it up based on the counties, so.
Jeff, how about if we just add to the motion that the commission approves to 3 counties, the allocation of 20, then that may introduce that specificity. LA has already been identified. We have to identify 2 others, but does
So
that make sense?
sure, we can change it to 3 counties per Commissioner and Sheriff Brown. Do we want to identify 1 small, 1 medium, 1 large, or are we good with the 3 counties?
I don't think ahead of time, because I don't think you know that. I don't think you know that until you reach out to them, which is what your plan was to do, correct?
Right, I just was, yes. Yes.
I think the problem with using the up to language is if LA County comes out and says, we'd like to have all 16 million.
Right.
I'm sure they could use it, but I don't know that necessarily that's appropriate either, that they should get it. I think it should be divided on a pro rata basis, or, come up with a way to divide it up.
Yeah.
So that it is equitable.
Yes,
to-
except the friendly amendment.
And Chair, that's part of the conversation here. And the original motion, as I understand it, did not include LA County specifically.
The motion doesn't.
No,
But it's
it doesn't.
clear from the staff report that LA has been identified as the.
I don't disagree with that. And I acknowledge, Sheriff, that LA is the epicenter, but the original motion doesn't say that. And so that's part of how this got a little bit muddy, because it became very specific to.
Maybe the answer to that is just to make the motion, just make it the large, medium, and small. Identify a large,
yes.
medium, and a small.
Yeah.
And just like the smaller medium county, we would justify that in January. We would also provide information about Los Angeles and why Los Angeles was
Yes, just
selected
same-
as
but
well.
same way,
But don't
same
have it
criteria.
listed.
Yeah,
Yes.
I mean, I think there's agreement here that LA is,
Yes.
the
New
most in
friendly
need.
amendment. I'm sorry, we need to move forward. We're going to lose a quorum, and LA County is, even so, we're going to lose a quorum. So I'm just really concerned. So if we can not list out then, and you can justify why LA County would be identified, but do not list it out. Is that
The amendment would be for a large, a medium, and a small county.
correct? And not list out any
That's how
specific
the 16 million. would
county.
be.
Thank you. Okay, Jeff.
So we have a motion as I read, with the tail instead being with the commission contracting with 3 counties, 1 small, 1 medium, and 1 large, as well as other entities.
I think I would identify in the pilot program, right?
All right, in the pilot program. Is that amendment accepted?
That's accepted.
I have the chair making the motion, and I have that could very well be. Is that
Thank you.
Commissioner Danovich? Is that your motion?
Yep, I support that.
And do we have a second to that, Madam Chair? The chair is the second?
Accept it, yes.
Okay, I just had those reversed. Okay. Per Madam Chair, I will now read the roll. Commissioner Bontrager. Commissioner Brown. Commissioner Bunch.
Aye.
Commissioner Carnavale. Commissioner Carrillo. Commissioner Chambers.
Aye.
Aye.
Oh, thank you, Commissioner. Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette.
Aye.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Excellent. Thank you. Thank you, everyone, for that. Learn and grow together. Thank you, Tom, for the presentation. Toby, thank you. We are going to move on to agenda item number 9. However, we have been sitting here straight through. I am going to take a 5-minute stretch break for everyone, and commissioners are going to be eating lunch. When we get back, we're going to do a working lunch. So a 5-minute stretch break for us. We will be back in 5 minutes at 1:35. Thank you, everyone. $1,450 over 5 years. Before we hear the presentation from LA County, I wanted to highlight for my fellow commissioners that we received an early draft of the Children's Community Care Village proposal in January of 2023. The proposal seeks to improve mental health outcomes for children through the leveraging of innovation dollars with additional funding streams to create a new mental health continuum of care for all children, with a particular focus on children ages 5 to 12 who live in South Los Angeles County. This proposal aims to serve the service area 6, which includes the cities of Athens, Baldwin Hills, Compton, Crenshaw, East Rancho Dominguez, and Watts, whose racial and ethnic demographics are mainly African American and Hispanic. After initial technical assistance to discuss the Commission's concerns regarding the use of innovation funds for capital investment, several commissioners and Commission staff went to Los Angeles for a site visit on June 21st of 2023. Following the site visit and additional technical assistance, the county proposes to reduce the amount of innovation funding allocated for capital and will utilize $25 million from their capital facilities and technical needs funds. So the county is now requesting the total of just over $100 million of innovation funds over 5 years, as I mentioned earlier. We look forward to hearing more about this proposal from Kayleen Gilbert, who is the Mental Health Program Manager for Los Angeles County Department of Mental Health. After the presentation, I welcome comments from commissioners, and I would really like to hear from those who participated in the site visit to share their thoughts on the visit and the revised proposal after we hear from the county. So at this time, I would like to invite Kayleen. Ms. Gilbert.
Before we start, Madam Chair, I'm going to recuse myself.
Thank you, Commissioner Bunch.
Good afternoon.
Good afternoon.
And thank you so much. I'm wondering, for the presentation, are you bringing up slides or shall I?
Cody, do you have the slides or?
Okay, I see them.
Uh-huh.
Wonderful. Thank you so much. So good afternoon, everyone. And commissioners, thank you again for giving us some time to present our Children's Community Care Village for LA County. My name is Kayleen Gilbert. I am the Mental Health Services Act Coordinator for Los Angeles County, and I'm fortunate, hopefully, to be joined by our Director, Dr. Lisa Wong. If she's not on now, she should be with us shortly. Let's go ahead and start. We go to the next slide. So I'd like to introduce the Children's Community Care Village. The Children's Community Care Village is a multi-service campus with a continuum of mental health services that includes outpatient and inpatient services, urgent care, crisis residential, and uniquely on-site housing. The services are available and accessible to children, youth, and families in South LA. And actually all over, but really we're putting this in the community of South LA, and includes campus-wide intensive care coordinators to support families as they navigate that system of care. So while ICC is a benefit, we are using it in this new way to assist families from the first service on site to transition between those levels of care, and using practices like child and family teaming to put them in the driver's seat to have that shared decision making. The goal here is to improve the quality of life for participating families by minimizing the disruption in the lives of the child, youth, and family in crisis to the greatest extent possible, empowering the family through intensive care coordination, ICC, and, as I noted, the use of child and family teaming, and prioritizing the coordination of care to ensure that right level of service at the right time. We do have a partner in this project, and that is Kedron. And Kedron has long, deep ties in the South Los Angeles community. They were established in 1965 to provide children's mental health services. And they have extensive experience working with children, currently operating children's outpatient and intensive services. And more specifically, I think they have, with those connections to the community, the treatment providers on campus are reflective of the community and their needs. If I can get to the next slide. So, in working with South LA, we want to first recognize that there are just a number of disparities in this community that we are trying to address here. I know I've brought a previous project here and we've talked a little bit more about this particular service area. So again, we're really focusing on the needs. South Los Angeles has one of the largest concentrations of poverty, twice the rate of California and national averages. It has the largest concentration of child welfare removals in Los Angeles County, resulting in significant disruption to children and family lives. Transportation disparities are present, with at least 17% of households are without a car, which impacts access to care, particularly for families that may have to attend to multiple needs or multiple appointments. And there are no existing crisis residential treatment programs for youth in LA County or anywhere, as far as we can tell, particularly for those ages 5 to 12. And currently there are no urgent care centers for children. And these are really important services and levels of care if we want to try to mitigate hospitalization and reduce that crises and disruption in the lives of our children and families. And South Los Angeles has a population that is about 23% African American, 69.2% Latino, 3.2% white, and 2.4 API. So quite a high concentration of underserved or inappropriately served communities. This is historically an African American community, but over the past number of decades has a growing Latino population. And any provider delivering services here really needs to understand the unique needs of this community, which we believe we have in our partner, Kedron. So addressing the needs of youth and family, this project proposes to meet those community needs in a way that is accessible and minimizes that disruption during a crisis, offers a continuum of care that ensures, again, the right service at the right time, engages youth and family in a way that puts them in the driver's seat and supports that shared decision-making process, provides supportive alternatives to hospitalization in a crisis that maintains that youth social and education structure to the greatest degree possible. So for example, one of the services that we were really looking and wanted to ensure was present here was the ability to maintain the youth in their school of origin. And this would be one of the roles of those ICC coordinators, to make sure that not only we're coordinating care on campus between these various services, but also ensuring coordination outside campus as well, up until the time that the child, youth, or family is fully connected with another service provider. And they offer on-site housing for families in crisis facing homelessness or who just want to be present to support their youth through the continuum of care. Next slide, please. So we see here, while we know that there are a number of services here that might not be new, there are several that are, and we really think that bringing these together into a single point of service delivery site that offers that full continuum of care is something new and something new for this community. Making sure that we pull all of those pieces together with that coordination is also, we see as one of our innovations. In addition to that 24 unit on-site housing. And in fact, a few of those units will also be used, outfitted for parent-child interaction therapy. So ensuring we can actually also meet the needs of young children in crisis. The first children's crisis residential treatment program, as I noticed, we don't have this service anywhere, and it is just desperately needed as that mitigating level of care before we get to hospitalization. So our learning goals: will having a scalable continuum of care in one location lead to better outcomes for children and families? Does having an assigned ICC coordinator expedite access to appropriate levels of care and reduce inpatient admissions? Is the provision of housing for children and families in crisis an effective solution for stabilizing lives, contributing to overall improved mental health outcomes, and reducing the participation or reducing the participation in the child welfare involvement? Next slide, please. So our budget, we don't recognize is quite large, and we recognize this is something new that has not been brought forth to the OAC before. So again, we do appreciate you hearing, are so grateful for your hearing our request. So innovations, this is a 5-year plan, and we intend for services to begin in year 1 on their existing campuses so that we can really pilot out that care coordination piece that we think is so essential. So the service costs over 5 years we see as at $34.8 million. And then we do have the capital request, which is a non-recurring cost at 65.7 or 65.8 almost $1 million. Now, a couple of things that I want to note about why one of the reasons this capital request is here is that if we want to develop a service, a continuum service campus-like service like this, there is just no ready-made campus in LA County that would allow us to do this. There's no place we can step into and rent or renovate easily. So it really is going to require building from the ground up. And we did look at models in which maybe we would purchase and rent back, but it's not efficient, and we don't see that as a good use of funds. So this and that plus Kedron has this property, so we're able to get in for less expense. So we see here, in addition to the innovations funding request, we have lots of other funding sources from public and private, so it's not just an innovations project. There is a $57.4 million grant from BHCIP. As noted before, there is a $25 million offer for CFTN from LA County, pending, of course, approval here from this OAC. California State Legislature has contributed $2.5 million. The LA County Board of Supervisors, Soup District 2, of $1 million, and then foundations and private philanthropy, another $1 million. I also want to note there are other services that are funded, right? There's an FQHC on campus. So this is really a partnership among a number of service sources and funding sources. So with that, I would love to hear any questions that you all have. We are really looking forward to having this discussion with you.
Thank you very much, Kayleen. I'm hearing an echo. Sorry. So, Kayleen?
Yes, I'm here.
Okay. I'm going to ask you maybe if you can mute just while I'm asking the question. Okay, better. I don't hear the echo anymore. Do you hear me fine over there? I'm going to assume so. Thank you, Kayleen, again. So the commission has had questions and some concerns about the project, and I'm not certain that the shifting of some of the funding has addressed all those concerns. So I have a couple of questions. And first, should innovation funds be used when there are potentially other sources of funding, such as CFTN, funds available to build structures? So that's just one. And then I had another question regarding capacity. So the county's Hollywood 2.0 innovation project was approved in 2019 for a little over $116 million. And this project faced several delays before launching. Does the county have the capacity to take on another $100 million project? So that was my second question. And then just finally, one more. In the past, the commission has approved LA innovation plans before the county board of supervisors has approved. And then it has taken years for the county to obtain the final approval from their board. So this is really something that we want to know more about. Where are we with the county board of supervisors in LA County? So if, the approval process there. So if you could just address some of those things that I know I have a question about, or we have questions about. And then once those are addressed, then I want to open it up to my fellow commissioners as well. Thank you.
Sure, thank you. And I'm sorry, first, may I ask, I don't know if you can see my video. My video is on, but I don't see the reflection here. Am I visible?
Oh, yes, yes.
Okay, so I just can't see myself. That's okay then. So I want to make sure, because I heard you say 3, but I took 2, the Hollywood 2.0 and taking on other, additional projects in the Board of Supervisors. So I'll start with Hollywood 2.0. And I think that we do know that I'm very aware that there were some delays in getting that project rolling. And then certainly then at some point, the COVID did not help. This was a very community-based project. So over the past year and a half or so, we have been in a much better position, certainly with hiring, with building capacity, and bringing on a manager. So that project has some great momentum and is rolling up. So I think we've also really improved a lot of our implementation strategy here. That and, our current director is really passionate about these projects and is ensuring that we have the support that we need to get them rolling. So that project, yes, delayed, is in motion. For this project in particular, it is a large amount, but a good portion of this capital is really ready to spend in the first 2 fiscal years. So the remaining service portion is what we will need to build up, and that will be over the 5-year period. So while it is quite a large project, some of those expenses will be pretty easily spent down. Did that answer the question regarding capacity in Hollywood, or may I speak to something else?
I mean, that was the concern, just how long it took with that. And then the County Board of Supervisors, right? So where are we with that?
I believe my director, Dr. Wong, are you with us? Do you want to respond to that?
We're happy to do that. Hello, everyone. I'm Dr. Lisa Wong, and I'm the new-ish director of the Department of Mental Health. So we know that we have some support on the board, but this hasn't gone before the board yet. We wanted to see, how the commission felt about this, and then, go ahead and socialize it with the board. We don't anticipate that we'll have objections because I think it's pretty widely recognized how needed this project is, and that it is such a different approach for us to, work with children and families this way. It really is a case of the whole being greater than the. I think somebody had muted me, but okay. So I don't know at what point I was muted, but I was just saying that this is really a case of, the whole being greater than some of its parts. So we're very excited about the possibility of bringing these services together in a very novel way. And we do recognize that we have a good deal of support for this, but no, we have not formally taken it before the board yet.
Not sure if there's no sound.
Those of us online cannot hear sound in the room.
Can you hear me now?
Yes.
Okay, sorry. So that's what I'm referencing specifically. The commission has approved, in the past, we had approved LA's innovation plan before the County Board of Supervisors had approved. And then it took years for the county to obtain final approval from their board. So we found that unacceptable considering the high level of need for services in LA County. So can we have a guarantee that that wouldn't happen again?
Yes, that will not happen again. We have a, very different board. We have a different administration in place with mental health. And I think just like how we expect a different pathway for Hollywood 2.0 going forward compared to the past, we think likewise we'll have that kind of process here. I mean, we've really made more progress in the last 6 months than we had, the last, 4 or 5 years on Hollywood 2.0. So I think we have a good idea how to move things forward.
Thank you. I appreciate that. Commissioner Chambers has a question. Thank you.
And maybe you answered this. I do see how you went through the process of your community stakeholder feedback. But I was wondering how many consumers, maybe that was on here and I'm just missing it, was engaged. I do see that you engaged Kedron and their board. I also am interested in how the process to select a bidder for these services, or was that, is there going to be a fair process to bid this out? Or is it just going to be a sole, I'm reading it, I'm just asking, a sole source with one agency that's a trusted agency? And also, I did see maybe one reference in the analysis to maybe peer advocates being used, just with the crisis in the workforce. I'm just a little surprised to not hear more peer support, especially with youth. And yeah, I think I had a couple of questions. I don't know if you were able to capture them.
think Kayleen can probably speak better to that.
I can start with, I'll actually start with the most recent one on peer supports and services. This is where, particularly with families, we did see we did include a component in this project that included like family advocates or parent partners that would be there on campus, not only to support the families there on site or the families there supporting their child or youth, but also to engage within the community. I think with youth bringing on, and I think there's opportunities there as well for that community engagement for both parent partners and for youth. To just, I think it helps us also raise awareness about the services and the service availability. So again, their role will be out in the community, making those connections, and their role is on campus, providing support to parents and to youth. So yeah, we didn't, I think, I don't think we expanded on that one quite as much as we did on some of the other pieces. In terms of the development, I have to share that the development of this project had predated me. But when I did come on board, I know that there are active folks with lived experience and community members that were part of the board that helped to develop this project on the Kedron side. We do anticipate that they are our partner. And so I would imagine on mechanism, I can't speak I can't speak specifically to that, but I'm imagining that that would probably be a sole source because they are our identified partner in this project. And in terms of then the more recent consumer, this was presented to our stakeholders. It was posted. It was actually included also in our last annual update as well. So we did put it out for comment. We didn't see any comment come back, but there have been opportunities too for input.
Is this common for such a large project to already just have the contractor, one person in the county doing all the work for this large amount of money?
I don't have another example of it, but I don't know if Dr. Wong wants to comment on that as well.
I'd say it's not uncommon when we're talking about very large scale projects where we're building on existing components, because this project doesn't just start everything up from the ground. It's really taking from some services and programs that exist, tying them together in a different way, and then adding missing components to that. And also, Kedron has the campus too. That is Kedron's campus. So it's a very unique situation, but not something that we've not done before.
Thank you. I definitely went on the site visit and was there, so got very familiar with the region. I live in LA. Definitely know the need about South LA. Just as a BIPOC, small, peer-run organization, I just find it sometimes concerning that we don't make the process more open for other people to bid. It seems like the counties get comfortable with who they know, because who they trust, and it doesn't allow for real innovation and integration for the people that are also doing the work, because it's easier to contract with who you know. So I just would like to encourage that I have you guys on the call to reach out to other people that are doing the work that aren't your regular contractors, because that's what we're hearing a lot, is that particularly large counties just go with who they know. And particularly now that MHSA is being moved to more of a Medi-Cal model, this allows for opportunity for LA County DMH and other counties to really look at those providers who are going to lose most of their whole budget, to really allow them to be able to do this work too in South LA. But yeah, thank you for answering my questions and listening to me.
Sure. Thank you. Thank you for your comments and, voicing those concerns. There are concerns that the department has had too. So we have really opened up our capacity to smaller CBOs, and that has been a part of our very intentional outreach. We had, in fact, a whole program last year that looked at doing community grants with only our smaller CBOs. And so that's something we continue to pursue. This was sort of more a unique opportunity where there was this wonderful campus available to do this kind of work that couldn't be brought together otherwise.
I just think that, like, just again, I'm probably familiar with what you're talking about, but I'm referring to legal entity contracts. CBOs need to do business with the county on not just a one-time, short-term. I mean, I think the focus should be looking at those small CBOs and how you could build their capacity to do business as a partner with the county with a legal entity contract.
Yes, we're definitely working on that also. We started with our incubation academy and we have plans to grow those efforts. So
If I may, Commissioner Chambers, yeah, our Incubation Academy, I think, has a cohort of more than 10 where we are trying to build up CEO's capacity to contract with the department or even with other large county entities. And we are renewing that effort this year. It is a big piece of the conversation as part of our planning process. We're in the middle of our planning for the 2-year plan that we're getting ready to roll out. And this has been a central theme that we really want to make sure we can incorporate into our services. And I think anything new that we're rolling forward in the next couple of years.
Well, I look forward to seeing the announcement about this incubator project that you're doing and the highlights and outcomes, because I have heard about it, but I'm more interested to see like who actually got helped. But I'll be looking out for that incubator. Thank you.
Thank you, Commissioner Chambers. Commissioner Danovich.
Yeah, thank you. Let me just say first that this is an incredibly compelling proposal, and I would absolutely love to see it come to fruition. Just, full stop. It's necessary and really, really vital. I think that the concerns I have are around how well this maps on to what innovation is supposed to do. The innovation mechanism is really designed to enable evaluation of new practices, initiatives, projects that can be kind of stood up quickly, learned from, and then not only sustained but disseminated to other areas. And this is a project that provides invaluable services and facilities, but the learning evaluative components of it appear to be small. And I think the link to the Hollywood 2.0 question is one of the learnings for us is the complexity of executing through the innovation mechanism in a way that can produce learning, these complex multifaceted projects that involve services and facilities and all these other pieces. So my question to you, I guess a comment and a question. The comment is, given that I know there are other unspent MHA funds that could be available, and I would love to see them dedicated and allocated to this because it's a meritorious project. With the innovation lens, what do you think are the learnings that would enable other counties that see this, if it were to be successful, to implement the same thing without a commensurate, capital and services budget to capitalize the innovation?
I think the biggest piece that we're looking to offer here is that coordination of care. And I think something we recognized as we walked through the different components of the existing campus where there's opportunity for learning how we can better integrate care and learning how, even if services aren't the all on one site is fantastic. And that is a big piece of it. But the ability to really hone in on a good coordination that stands outside of the services and really guides the families through that process, I think is one of the bigger learning opportunities that we have here. I don't know, Dr. Wong, if you wanted to respond as well.
No, I think that really sums it up. I mean, it's basically, Kayleen, like what I had mentioned, that, our big learning from this is being able to take separate pieces that are all valuable pieces, but weave it together in a way where the families can benefit, at a different level. It's at an exponential level. What happens when everything actually wraps around the family, wraps around the child in need? And what kinds of increases in positive outcomes can we see because of that?
And just a last follow-up, have you looked at the other MHSA funds that could be applied to this? And if so, what are your plans with respect to them?
Well, one of the first things I did actually when I started in this role was to sort of do a deep dive into all of the existing MHSA funds and what the encumbrances were, what allocations we had actual or planned. And so we before, SB 326, we were already on a track for fully utilizing everything. So we had allocations planned. I think we're going to have to make some adjustments given, the possibility of upcoming changes. But we had already increased the utilization by 16% in the first half year, and then we were going to be up to 72% increase this year. So we had things already allocated that are in the works. We have a lot of building, a lot of housing, a lot of different programs that we're launching, increases to support the special programs that LA County is engaging in, like our early implementation of Care Court, our homeless state of emergency,